managing the second stage of assisted vaginal delivery, as I just mentioned, and using vacuum extractor or forceps is an important skill for managing the second stage of labor. So each labor attendant usually should be familiar with using these two instruments, as emergency may arise at any time. And as we know, labor is a dynamic process, and at any time an emergency or an elective indication for assisted vaginal delivery may arise. In our talk, the objectives of the next slide, Maaz, we are going to discuss the indications and prerequisites for the vacuum and forceps use, and discuss the pelvic landmarks and define the instruments and procedure that we need to use during assisted vaginal delivery. And in the mega delivery station, when you arrive in this situation state, usually you are going to be demonstrated on how proper to use equipment on mannequin and fetal, maternal and fetal mannequin. Next. Assisted vaginal delivery, as I just mentioned, is an important skill for those who are managing labor, and particularly the second stage of labor, and all maternity care needs to be familiar with the skills and using the vacuum and the forceps when emergency situation arrives. The rate of operative vaginal delivery has steadily declined worldwide, and in the United States in 1990, only 3% of live births, all 9% of live births were delivered using operative vaginal deliveries, and in 2013 it declined to 3.3%. So it's regressing because usually people are moving toward doing emergency cesarean section rather than doing assisted vaginal delivery. This is because of lack of experience and the fear of failing, and then usually going, which increases the trauma for both the mother and the babies. Vacuum deliveries now comprise 2.7% of deliveries in USA. This data usually reflect the evidence from USA. And the forceps deliveries now comprise only 0.6%, less than 1% of vaginal deliveries are delivered using forceps assisted vaginal delivery. And surveying the OB-GYN residents or trainees, so only 50% of senior trainees at the home mentioned that they are competent to use the forceps, while more than 90% are competent in using vacuums. So the use of vacuum is rising compared to use of forceps in assisted vaginal delivery. One of the aims of using assisted vaginal delivery is to avoid emergency cesarean section in the second stage of labor. As we know, or that second stage cesarean section is associated with a lot of complication and long-term sequence. So assisted vaginal delivery is an important tool to safely prevent and reduce the cesarean section. And fewer than 3% of vacuum-assisted vaginal deliveries go on to be delivered by cesarean section. That means that they fail, and then they are converted to emergency cesarean section. Regional differences in the vacuum use indicate variable decision-making with a range of 1 to 23% births across the United States. One way is usually that we can use the prevention of emergency cesarean section, usually the positioning of the lady in the labor, while in the second stage, because as we know that upright position and lateral position increases the chances of success of vaginal delivery, and reduce the duration of the second stage in labor, but small increase in the second degree prenatal stage. In addition, supporting person associated with reduction in the length of labor and reduce the likelihood of operative vaginal delivery. Nulliparous with epidural anesthesia may benefit from oxytocin augmentation in the second stage of labor, usually to increase the force of uterine contraction, then usually the power of expelling the baby per vagina. In the instruments that we use in the assisted vaginal delivery are vacuum structures and forceps. The vacuums, and usually vacuum structure اللي هم milestones. Historical rigid metal cup اللي هم this was the old one اللي هم usually is connected to a separate suction machine, and soft plastic cup اللي هم introduced, which was a choice of most situation for the occiput anterior position, and the rigid plastic cup for occiput posterior. And nowadays also we are using the rigid occiput posterior plastic cup اللي هم usually that's available here in Sudan, and we use it in teaching in the also courses. The forceps, and there are several types of forceps: Simpson's or outlet forceps, mechanical forceps, and most situated for the large molded head. Piper, and Killen forceps, and or has special indication. So when we are talking about forceps, we are going to use the Simpson's forceps in the also. One of the things that we need to mention is that usually regarding the second stage, now the definition has changed from mentioning that the labor of 2 hours in the naive process is regarded as prolonged labor. Usually increase the waiting hours to 3 hours, and in multiples to 2 hours. Usually, this is to increase the chances of vaginal delivery, and that's for those who are not having epidural or regional anesthesia. For those who are having regional anesthesia, usually in naive process we can go up to 4 hours, while in multiples we can wait up to 3 hours, regarding provided that the fetal tracing is reassuring and everything is fine on the descent is progressing. So there are indications for using assisted vaginal delivery. We have maternal indication and we have fetal indications. Maternal indication usually could be prolonged second stage, and usually, as I just mentioned, that the second stage is regarded as 3 hours in naive process and 2 hours in multiplex without anesthesia, and it was just 4 hours in naive process and 3 hours in multiplex with regional anesthesia. Prolonged second stage could be either due to maternal exhaustion or drug-induced anesthesia, soft tissue resistance with a failure to descend, or sometimes usually instrumental delivery may be indicated electively for those with maternal illnesses such as cardiac or respiratory disease, or those who have increased intracranial pressure, or occasionally when you are encountered with indeterminate intrapartum hemorrhage in the second stage. So usually we need to expedite the delivery and then look for the cause or the source of bleeding. Regarding fetal indications, fetal compromise is necessitating immediate delivery in the second stage. So this is the major indication of delivering the baby. Slides. The fetal compromise necessitating immediate delivery in the second stage, persistent category C CTG, or concerning category 2 fetal heart rate. So we have maternal indications, as we just mentioned, and on the other hand, we have fetal indication, and most of them are usually emergent, and that needs usually expediting the delivery of the baby. So when we are conducting instrumental delivery, there are certain prerequisites that we need to fulfill before conducting the instrumental delivery. These are usually that the baby must be presenting by vertex. The cervix must be fully dilated to avoid the lumocervical tears if the cervix is incompletely dilated and you try to deliver the head. The membrane should be ruptured before applying the instrument, whether it's forceps or vacuum extraction. Most suspected cephalopelvic disproportion. If there's any doubt that there's some degree of cephalopelvic disproportion, it's better to deliver the baby using emergency cesarean section rather than conducting instrumental delivery, and that will lead to failure, and then revert to cesarean section, is increasing the prenatal or maternal and fetal morbidity. Another important thing is that usually when you are conducting instrumental delivery, you have to have a willingness to abandon the procedure when you see that there is no progress within a reasonable time or within several attempts. Engagement of the presenting parts is crucial usually before applying the forceps, and usually it can be felt either per vaginal examination or palpating how many fifths of the baby's head is palpable per maternal abdomen. By engagement, simply you mean passage of the biparietal diameter through the pelvic inlet, the leading edge of cetal scalp, or at or below the ischial spine, which is regarded as the zero station. Classification of assisted deliveries and outlet forceps or vacuums. Usually the fetal head is lying on the pelvic floor, fetal scalp on the pelvic floor, and the scalp visible in between the uterine contraction per introitus, and low forceps or vacuums where the presenting part is more than 2 centimeters below the ischial spine, or mid forceps or vacuum where the head is above +3 station, and we need to avoid the term high or the high forceps. So when you are doing assisted vaginal delivery, you are either going to use the vacuum structure or the forceps for delivering the head. The vacuum, often the instrument preferred, as we just mentioned earlier in the beginning of the lecture, and it have soft bell-shaped cups, can minimize the maternal fetal trauma, or the rigid cups that are used for the occipital posterior. And as I just mentioned, here we are using the rigid cups for the courses of also and in our hospitals. And in the image, you can see that different types of forceps. And on the left one is the rigid cup, and the silicone, and you can see that it's connected with a tube that usually can use a separate machine for creating a negative suction, while on the other hand, this is a soft cup, where usually you can still use it, use a single hand and to create a negative pressure. Folding cups, and you can see again here is the bell-shaped cup, and it can easily be pressed and to be introduced into the vagina, and then usually applied on the fetal hip, and usually M cup, usually which is not used constantly or commonly used here. The incidence of severe base trauma with assisted vaginal delivery has been evaluated. Low risk usually is regarded as in normal vaginal delivery, where the risk for maternal and fetal trauma is minimum. And intermediate risk where delivery by forceps or vacuum or even by cesarean section, again usually, while in the high risk is regarded, high risk for maternal and prenatal trauma is regarded where combination of two methods is used. For example, failed forceps or failed ventus converted to emergency cesarean section. Addition or extraction, vacuum extraction converted to forceps usually increases the risk of maternal and neonatal or fetal trauma. Delivered by cesarean section following forceps, and again usually increases the chance of prenatal trauma. And again usually for abnormal fetal heart racing. So in conducting, as usually we use in also we use the acronym A, B, C, D, E, F, G, H, I, J in conducting the whether the vacuum extraction or in the forceps. I'm going to start with the vacuum extraction or vacuum application. So A in vacuum application stands usually for asking 3 A's. So you have to ask for help because it's an emergency where you need an extra hand to help when you need. You have to address the patient, to explain the patient the procedure and the necessary for conducting the instrumental delivery. Just simply telling the mother that the baby's fetal heart racing is not reassuring while the baby is lying down in the pelvic floor. So we are going to use a vacuum to assist the baby to be delivered quickly. Another important things in A is usually to make sure that you have adequate anesthesia. If the lady has already epidural anesthesia, that's enough. If not, usually we can use a epidural block to provide adequate anesthesia for delivering the baby. So A, ask for help, address the patient. So simply explain to the patient the indication for the procedure and how we're going to deliver, to assist in delivering the head, and give an adequate analgesia or anesthesia, either epidural if it's in place, or usually put under block, or sometimes even local infiltration in the perineum may be adequate. B stands for bladder should be empty, and usually if the bladder is not empty, usually you can just simply insert the Follic catheter to empty the bladder, because this will assist in delivering the preventing partner and prevent the trauma to the bladder. The cervix, C stands for cervix, and here we mean that the cervix should be completely dilated. So usually there's no place in attempting whether vacuum structure or forceps in completely dilated cervix, because that's going to increase the chances of cervical trauma and bleeding postpartum needs. So usually to avoid that, usually make sure that the cervix is completely dilated. So again, for the vacuum, usually D stands for determination of the position, and determine the position. Usually we have to do vaginal examination to see where the fontanelles are, and here usually you have to know the anatomy of the fetal skull. And if you are going to palpate for the posterior fontanelle, usually it's triangular in shape and smaller in size compared to anterior fontanelle, where it's diamond in shape and it's wider. And if sometimes there is a presence of caput, usually it may be difficult. And here you have to go laterally to feel the ear of the baby, and usually to see which direction the head, the ear bends. So determine the position, and lower anterior face is larger, posterior fontanelle is smaller and Y shape. Bending of the ear again is another help that you can use it, and molding makes assessment again difficult, because usually the fontanelles may become smaller, and usually their shape may even be indistinguished from each other. Again, while you are determining the position, you have to think of shoulder dystocia, that usually following the delivery of the fetal head usually may be encountered with shoulder dystocia. So quickly, people around you should either have the mnemonic helper, and be ready if you are encountered with shoulder dystocia following successful delivering of the head. Cesarean delivery indicated instead of operative delivery. The risk is acceptably high, and usually following failure of the assisted of the vacuum. And extended versus extended head versus flex head. I guess these two images show where usually in the flex head, and the presenting diameter is 9.5 centimeters, while if the head is extended, it goes up to 12.5 centimeters, usually making the delivery a little difficult. So you have to keep in mind where you are applying the vacuum. Usually you have to apply it in the place where you create maximum flexion, or we call it flexion point. We'll see it in a few minutes. Okay. The next slide. Flexion point. This again, usually the image is showing the flexion point and its relation to the anterior and posterior fontanelle. The flexion points rise around 3 centimeters from the posterior fontanelle. So you have the center of the cup should be applied on the flexion point, because if you applied it more anteriorly, that's going to cause deflection of the head, and that increase the diameter of the fetal head. And when the cup is applied, and maybe the edge of the cup is going to just lie with the posterior fontanelle, and it's going to be around 3 centimeters from away from the anterior fontanelle. E stands for equipment. Usually we are following the acronym A, B, C, E, D, F, G, H, I, J, and E stands for the equipment. Make sure that your vacuum is ready and is functioning, and you can test that simply by applying the cup on your palm of your hand, trying to create a negative pressure, and usually it will be stuck to the palm of your hand. And the flexion point, as we just mentioned, is the proper application. F for flexion point, and usually you just explain the flexion point that is usually 3 centimeters anterior to the posterior fontanelle, and while you're applying, the edge of the cup is going to reach the posterior fontanelle. Again, one of the important things usually you have to feel for FT to feel that there is no maternal tissue interrupted between the cup and the fetal skull, because it's going to cause maternal trauma and severe maternal trauma, and later on bleeding when the baby is delivered. So before creating any negative pressure, usually you fix the cup of the vacuum on the fetal head on the floor in the flexion point. Simply use the other hand all around the cup to make sure that there is no maternal tissue interrupted in between the cup and the fetal skull. Compression of the soft cup insertion, usually just separate the labia and vagina, and usually compress the cup and usually insert it. And gentle, G stands for gentle traction at the right angle. So here usually when you apply the cup in the flexion point, you have the direction of the traction should be right angle to the cup. Only during the contractions, when you apply gentle in between during the contraction, one with the maternal effort to assist in descending of the predental part and delivery of the fetal head. Bending or rotating force will cause detachment of the cup and possible injury to the baby. So while you are thrusting, just make sure that you are just gently thrusting perpendicularly to the level of the cup. And here we can see that usually just lying directly, usually without bending or rotating. Again, rotating is increase the risk of injury to the injury to the fetal skull and cause lacerations. Next. So if you apply the traction the way we just mentioned, usually the mechanism of delivery will follow, and then the baby will spontaneously rotate when it will rotate when it comes into the maternal pelvis, and then the flexion will follow. And usually you can notice that the direction of your traction is going to change as the baby changes its position during the passage through the base canal. It's hold. When do you need to hold? So as we mentioned earlier, for the gentle traction, that we apply the traction with the triangle contraction and the maternal effort. We need to hold when the contraction subsided, and we need to hold if 20 minutes passed when we fail to deliver the head, or the cup pops off 3 times, and usually without 3 pops off, usually again an indication to give up the procedure, and so you have to hold the procedure. 3 contractions with no progress. If you apply 3 contractions and you see that the head is stuck at the same level, there is no descent again, you have to stop. So 3 disengagement, 3 contractions with no progress during the pull, and after 20 minutes of the total application. And some people even reduce the time to 10 minutes. Even if you try for 10 minutes without successful attempt, usually you have to abandon the procedure and you have to go for emergency cesarean section. For vacuum applications, again, usually I stands for evaluation for incision. So if your procedure is successful and the head is descending and stretching the perineum, you have to evaluate whether you need to do an episiotomy or not. If you have a lax perineum where delivery can be completed without episiotomy, that's good. If you feel that usually this endanger the perineum and risk of uncontrolled perineal tear, you usually can do mediolateral episiotomy to avoid the perineal trauma. And J, the last usually in the cranium is the J, and you have to remove the vacuum when the jaw is reachable. So if the head descended and the jaw is reachable, you distribute your finger in the vagina, which will reach the jaw. Usually you have to disengage the cup and then usually continue delivering the head delivering of the head of the baby using your hands. And again, usually you have to be aware not to use extensive forces. Usually, as we have to bear in mind that shoulder dystocia might follow instrumental delivery. As any procedure, vacuum is not free of disadvantages or complications. One of the disadvantages that it requires maternal effort and cooperation. So in forceps, usually you can apply traction without requiring maternal effort, but here we have to ask a mother usually to be cooperative and push while there is contraction to increase the chances of successful vacuum extraction. May take longer time than forceps, although the evidence is mixed, usually because here in between the contraction, usually you hold the procedure or you stop the traction in between the contraction. So that makes the procedure longer. Proper placement and traction are necessary to avoid injury and or from losing the vacuum, and increase the risk of cephalic hematomas and subgaleal hematomas. So that's regarding the vacuum extraction. Again, babies are at risk of complication in vacuum extraction. The most serious is subgaleal hematoma. Although it's rare, but potentially fatal, and subgaleal hematoma have mortalities from per 1,000 usually in 1994 to 1998 in USA. Increased risk of intracranial hematoma is one of the complications, a serious complication, and it could be ventricular, subdural, or interstitial. Retinal hemorrhage is one of the complications, commoner in vacuum extraction compared to forceps. And again, jaundice, because of the cephalic hematoma, usually the babies are at risk of developing neonatal jaundice. Another important thing is that usually obtaining a written and verbal consent is important, once this complication may arise, and then usually the defecation process may start, usually if the mother and the parents were not counseled properly before the procedure. So again, usually addressing the patient is important. By addressing the patient, usually explain the procedure and simply usually mention a few complications that can occur. Subgaleal hematoma and subdural hematoma. Subgaleal is just beneath the scalp, and while the subdural hematoma is just beneath the dura. Cephalic hematoma is just beneath the scalp, and subgaleal hematoma is beneath the periosteum. And it's a serious one, and it's just attached. It's limited to the affected bone. Commonly occurs in the parietal contraindication for conducting vacuum extraction is prematurity, where the baby is less than 34 weeks gestation. As next slide. Next. Breech or face or bra presentation, where usually we can apply the vacuum in neither of these. Where the baby is transverse or incomplete cervical dilatation, as you just mentioned, because of the increased risk of cervical trauma and postpartum hemorrhage and the sequel of postpartum hemorrhage. When the head is not engaged, again, usually we don't have to attempt vacuum extraction. What we need to do after successful or failed vacuum extraction, maternal and vaginal examination should be completed to exclude that there is no cervical laceration or cervical tear or vaginal lacerations. Newborn should be examined for presence of trauma, formation, cephalic hematoma, scalp laceration, and subgaleal hemorrhage, and hyperbilirubinemia. So again, babies need to be examined properly and followed usually for hours or sometimes even to be admitted to intensive care baby units for further assessment. The other instrument that we use is forceps. Next slide. Forceps. And again, usually we are going to use the same acronym for conducting the forceps delivery. A stands for asking for the help, as we just mentioned. Usually need extra hand if necessary arises, and you have to address the patient. And by addressing the patient, explain simply the need for conducting the instrumental delivery and what to expect to the procedure to be conducted, and the need for analgesia. And analgesia, we need to usually, if epidural is there, that's adequate. If not, then usually you can either use local infiltration of the perineum, or usually can use a blended flow. So ask A stands for ask for help with the patient and ensure that you have adequate analgesia. B stands for bladder should be empty, and usually simply by just inserting the catheter, usually you can make sure that the bladder is empty or not. If this is palpable, usually you have to insert the catheter empty. C stands for cervix. Similarly, you have to make sure to around the fetal head circumferentially to make that there is no remaining cervical limb before applying the instrument or before conducting the procedure. D stands for determining the position, as we just mentioned, determining the position of the head. And again, we have to think of this posture because joint delivery is one of the procedures that can be followed by shoulder. So you have to prepare yourself and quickly revising the helper pneumatic. Below shoulder dissociation in case of it happens. There is indicated instead of operative vaginal delivery if the risk is unacceptably high. Okay, if you're feeling that usually forceps may not successful, usually it's better to go for elective cesarean rather than attempting forceps and then going for cesarean section because this increases the morbidity. You simply just convert the patient from intermediate risk to trauma, usually to high risk of trauma. Equipment, if we start for equipment, and equipment should be ready, normal resuscitation tray should be ready there, and delivery tray should be ready. F stands for forceps application, and forceps application articulate the both forceps, make sure that usually they are the correct pair and they easily articulate and disarticulate, and place the left plate in the left hand and the right plate on the right hand. Apply the left side of the mother in the maternal left side first, and as we see, the forceps has usually parts we just explain in a minute. Cephalic curvature towards the vulva and the shank vertically at the start, you hold it perpendicularly to the contralateral inguinal ligament. The right hand is introduced in the vagina to protect the maternal tissue from being damaged by the forceps, and gently slide the forceps. This will be demonstrated to you in the workstation clearly. And repeat the same thing in the right side, while you're producing the right plate on the right side of the mother, and articulate the hands and locks. And they should lock easily. This shows the different parts of the forceps, and we have a handle, and the lock is just usually that is sliding, and between the lock and the plates, the shank, and it could be short or long depending on the type of the force. And here then we have fenestrations. Each plate has fenestration, and the fenestration at the top of it is the toe, and approximately towards the shank is the heel, and it has two curvatures, and pelvic curvature that is usually sliding upwards, and the fetal curvature where it accommodates the fetal head. Checking the forceps, and usually it's important before usually applying any traction. So after introducing the forceps and locking the forceps, usually we have to check for the position of safety. Usually that here we mean that the posterior fontanelle midway between the shank and above 1 centimeter above the level of the shank. The fenestrations admit no more than a tip of finger on both sides. The lambdoid sutures are equidistant above the level of the forceps, and the second suture is in the midline at equidistant between the two plates. So if all these are fulfilled, it means that your forceps has been applied correctly, and then usually we can continue to apply the traction. So G stands for gentle traction, and in Payos maneuver, we apply the traction in Payos maneuver. You can see in the image, it's usually the forceps is applied on the fetal scalp, and the two hands are used. One is holding the handle and applying tractions perpendicularly, and the other is or horizontally, and the other hand is used either it can be used from above or from down to apply downward thrushes. And this is usually to simulate the process of the mechanism of labor, so that the baby's head should slide in the pelvis and usually in the pelvic cavity, smoothly simulating the normal delivery. Initial tractions downward, then sweep in the large J-shaped maneuver. That's called pelvis maneuver. And non-dominant hand exerts downward traction, causing two vertical force, horizontal and outward, and vertical downwards. Following application of forceps اللي هم handle elevation اللي هم usually while you are applying the traction, the head is descending, usually reaching the pelvic floor. Usually you have to elevate the handle of the forceps, usually to allow the fetal head to sweep in the pelvic structure. Usually is simulate the J-shape J-shape of the pelvis. I stands for evaluation for incision of the, and again, as we just mentioned in the vacuum, typically usually if the perineum is stretchable and the head can be delivered without it's better. If you need that, the perineum needs to be is at risk of being injured. Usually it's better to perform a episiotomy and deliver the head, and usually the episode can be repaired following the delivery of the head. J stands for removal of the forceps when the jaw appears. Again, similarly, we remove the vacuum when the jaw is reachable. Again, here in the forceps, when we reach the jaw, or the jaw is delivered, usually we have to remove the forceps. And removing the forceps is opposite the insertion. In the insertion, we insert the left one first, and in the removal, we remove the right one first, and then the left one again. Usually, you have to slide in a similar way that you apply it to avoid injuring the maternal tissue and injuring the baby at the same time. Again, following successful forceps delivery, maternal, cervical, and vaginal examination should be completed, and if there is any vaginal laceration or cervical laceration, usually they need to be repaired according to the degree of the tissue injury. Newborn should be examined again, usually for base trauma, fracture of the clavicles, and if it's complicated by shoulder dystocia, cephalic hematomas again can occur with the forceps lacerations or abrasion in the forceps, facial nerve palsy, particularly if there is malposition in the forceps, and the forceps marks are normal usually, and this reassure the mother that these are going to disappear within hours or maximally 24 hours. Then the episiotomy should be repaired. And what we mentioned applies for occipital anterior position endeavor. Again, usually the same could be applied for occipital posterior position, but usually if there is malposition, usually we have to avoid using forceps. So when you're applying, it should be used either for direct occipital posterior or occipital anterior. Attempt for occipital posterior, usually before applying the forceps, usually attempt manual rotation before the insertion of the vagina, or usually it can increase the chance of spontaneous vaginal delivery before applying the forceps. Killer forceps rotation is you are trained and usually can be used, but again, usually if not experienced, avoid doing that. More anal sphincter lacerations can occur in occipital if the baby is occipital posterior, and you use the forceps in delivering the baby. Rigid posterior plastic cup or kiwi, again, usually more has associated with small failures than in occipital anterior. So after completing or successful assisted vaginal delivery, you have to write an operative vaginal delivery notes. And usually, preoperative diagnosis that this is a prolonged second stage, and or fetal distress in the second stage, estimated fetal weight, position, and the risk factors, shoulder dystocia, and operative diagnosis. Again, that this was just prolonged second stage, fetal distress. Operative operation, how it was done, usually how the insulin applied, the use, people attending, help use from needs from another person, and history, first stage of labor, how long, how was it going, second stage of labor, procedure A, B, C, D, E, F, G, H, I, J mnemonics, including the verbal written consent from the mother or verbal or written consent from the mother when it was obtained. And the third stage of labor again usually should be completed, and that no complication in the third stage. So at the end of my talk, usually nearly 3.3% of all vaginal deliveries are operative or assisted using either vacuum or forceps, and commonly people are using vacuum than forceps. And all maternity care clinicians should be familiar with the instruments, techniques for their use, because usually necessary may arise. And one of the important things that I usually tell my staff that is usually they have to try using the forceps, particularly in delivering the baby during the cesarean section, because similarly, usually you have to apply it in the same way, and usually you are opening the abdomen, so you minimize the risk of injuring the baby, and while you are getting the experience of applying the forceps in the right way while you're in a comfortable situation. The mnemonic A to J provides systemic method in assisting in conducting assisted vaginal delivery, and this is one of the important things that usually they also provide people with, and usually helping in making the procedures following a systematic way and in a proper way. Clinicians should be aware of complications and contraindications for those procedures. So again, usually you have to tell the mother that there is a risk of complication, and again, usually, as we mentioned earlier, that you have to be willing to abandon the procedure if you feel that this is not going to deliver the head or going to cause more trauma. That's the end of my talk. Thanks for being with me. And if you have any questions, just forward them.
Thank you very much, Dr. Siddig, for the elegant and the nice presentation. نحن لسه معانا زمن كويس، ممكن نسأل أكثر من 6-7 دقائق لحد ما يجينا جروب بدر الدين اللي حيبدأ واحدة، فيا ريت الناس تسأل، ودكتور صديق حقيقة ممكن نستفيد منه حتى لو ما أسيست. أي ناس عندهم سؤال في حاجة تانية أو في المحاضرات اللي فاتت ممكن نسأل عن كل حاجة يا جماعة. دكتور صديق في كل حاجة ممكن نسأل، أي حاجة لها علاقة بالحاجات اللي فاتت كلها أسأله عادي جدا وما في أي مشكلة. ويلكم يا شباب. وقف الشير. اتفضلوا. غير رافع يده، تفضل. عندنا سؤال يا شباب لدكتور صديق؟
يا دكتور السلام عليكم.
عليكم السلام ورحمة الله.
بس أنا جونيور شوية في السؤال، بس confusing me as a practitioner يعني. إذا الفورسبس والفيكوم failed والوضع كان critical يعني, do I have a specific time before rushing to the cesarean section؟ يعني what to do في الليبر روم إذا failed في البروسيدر بتاعت الفيكوم أو الفورسبس؟
طيب, if
to the best actions to be done.
Thanks for the question. As we just mentioned, in Allah, we have from the beginning usually to assess the chance of success for vaginal delivery, assisted vaginal delivery, and we have to bear in mind that at any time we may have to stop, and if you stop, and the other, what's the alternative? And usually here, if it fails, preferably to go for cesarean. And if you are in maternity hospital, usually the theater will be available for emergency cesarean section. And again, usually we have to notice in Allah theater attendants available when you are conducting the delivery, because if you fail, you have to convert it immediately to cesarean section. In case of vacuums, usually there is place usually to go for forceps, but with very cautious, and usually if again it failed, and هم doing two assisted vaginal deliveries, when failed, again usually go for cesarean section. This increase the chance of maternal and prenatal trauma. So usually you have to anticipate the complications, you anticipate what's going to happen. You feel in Allah this is an easy forceps, the head is low down في البلبيس you can. الحاجه الثانيه انك usually you have the support from a senior one. يعني احنا دائما واحده من الحاجات اللي also بعلمنا انه والله you have to ask for help. وانت ماشي تعمل الفورس حقينك اللي هم make sure that the senior person is available with you, or at least حتى اذا ما ذات senior ممكن يكون ان هم at the same level لكن more having somebody with you really give you support and بتخليك at ease يعني. And هنا انا بتذكر نقطه انا وسري سراج من الفوسيف في خرطوم teaching hospital, and I admitted a lady for vaginal delivery وانا مغطي في الحوادث يعني. I was called for the emergency section. طلعت من السيت جيت just have a look في الليبر روم لقيت they are trying to assist to perform assisted vaginal delivery for the patient that I introduced. الكلام ده بدري قبل ما look at that, and also courses ما كانت available. ف I feel in like he has difficulty in applying the forceps. I just usually ask her, let me help you, and I help her. I applied the forceps. Usually it was gentle, and usually we succeeded to deliver the head of the baby. But unfortunately, we were faced with the shoulder dystocia, and that was the first shoulder dystocia that I encountered. I realized it a little bit late, and usually just applied traction, and it was needed. I feel that usually they may trauma to the baby and we delivered that baby, and we ended with, we noticed that usually we had AF's policy, and usually we immediately noticed the pediatrician, and we go counsel the mother that what has happened, and we called the person caring for the patient, and luckily it was mine that usually I followed that lady and make sure that it reverted that. Having a support with you is crucially important, and usually when you are doing any procedure.
شكرا دكتور صديق. دكتور صديق خلينا نرحب ببروفيسور بدر الدين، بيسلم عليك وهو موجود معنا، ونحن الايام دي سعيدين هو موجود معنا لليوم الثاني.
السلام عليكم.
الله يسلمك. معي دكتور.
السلام عليكم بدر الدين، كيف اخبارك؟
اهلا صديق، كيف حالك؟
الحمد لله والله، كيف صحتك؟ ان شاء الله طيب.
الحمد لله انتم كلكم كويسين.
سعيدين بانه نشوفك معنا في الاوسط ثاني يعني.
الله يخليك الله يخليك الله يخليك.
سعيدين بالجهد اللي بتبذلوه يعني في السبورت الناس اللي الفاكولتي في السودان يعني. ان شاء الله ربنا يتقبل منك.
الله يخليك، شكرا. ان شاء الله انت كويس والعائله كويس كلهم بخير.
كيف اخبارك؟ ان شاء الله طيب.
الحمد لله صديق، الحمد لله. احسن لعبكم في زكي مصطفى يا اخي، استاذ زكي مصطفى الله احسن.
الحمد لله
يا اخي، ربنا يحفظه عنك.
الحمد لله، ربنا يحفظه الله يرحمه ان شاء الله يا اخي.
الله يخليك.
فقد عظيم والله. تحياتنا للاخوان كلهم هناك ولاسرتك الكريمه ان شاء الله.
يا صديق كثر خير يا صديق، شكرا.
شكرا دكتور صديق، ومرحب ببروف بدر الدين.
مرحبا بكم.
كيف صحتك؟ الله يديك العافيه. مرحبا بك يا بروف.
الحمد لله
الحمد لله في نعمه، الله يديك العافيه ان شاء الله يا رب. شكرا جزيلا، تفضل.
شكرا
يا دكتور صديق، شكرا جزيلا. بروفيسور بدر الدين مرحب بك، ونحن سعيدين بك، وزي ما قلت لكم المره اللي فاتت بروفيسور بدر الدين اضافه كبيره وفائده كبيره، والحمد لله احنا كل ما نحتاج له قاعدين نلقاه، كتر خيره، وهو دائما موجود معانا وهو سبورت بالنسبه لنا. قامه كبيره، بروفيسور في جامعات قطر، في الميديكال سكول، تشيرمان للاوبشن جاينا، اومن هوسبيتال، حمد ميديكال سنتر كولابريشن، وهو متخصص اكثر في الفيتال ميديسين، في البرينيتال. عنده اكثر من 100 بيبر، عنده اشهر كتابين، عنده عدد من الكتب اشهرهم في الالترا ساوند. اضافه كبيره، سي في كبيره جدا. شرف لنا انه يكون موجود معنا، وشرف لنا انه يكون كل ما نحتاج له نلقاه. شكرا يا بروفيسور. مرحب بك للمرة الثانية وشرفتنا كثير. Welcome.
شكرا جزيلا. شكرا. Is the light okay? Can you see me? Can you see me clearly?
Yeah, okay.
Right. I'm gonna put the light on and tell me which one is better. Just hold on. Is this one better or the one before? The same?
Yeah, nice.
Okay, good. Then we are okay. I'm going to share my slide now.
Yeah. Welcome.
Mandy? لا it's okay, but I just want to tell you الموضوع ده اتحل خلاص. I'm going to start now. Bye bye. Bye bye. Can you see the screen?
Yeah. Here.
Right. Please, I just want to, sometimes I get worried because your kids were not hearing me. So I'm going to ask you a question at some time, just to make sure that you are there. And please feel free to stop me asking me questions. It's a long lecture, and I don't want to keep talking for the whole hour without you asking me questions. So please feel free. When I pause, you can ask me any question. I don't get it at all, so I will welcome that. Now, I've just learned that you are a gynecologist and physician, and today is to talk about the ultrasound. And also, just to start with, I wanted to make a point that ultrasound is done at 3 levels: level 1, level 2, and level 3. And also, you are supposed to do less than level 1. And also, you are supposed to do less than level 1. It's a basic information about ultrasound, which will help you to apply your knowledge at the point of care. So I'm going to discuss with you in the coming 50 minutes or so about point of care, basic ultrasound assessment. Now, because you are all young and you are just starting your career, I just want to let you know, please, you have to learn ultrasound. It doesn't matter what you want to do at the end, whether you want to be a fetal medicine person or gynecology person or IVF person, you still need some knowledge about ultrasound. When you decide to go for fetal medicine, then you need much more knowledge about ultrasound. But as a physician and gynecologist, nowadays, you cannot practice optimum OBGYN without knowledge about ultrasound. And I always say to people, I always repeat the same sentence: no service is better than bad service. So if you want to use the ultrasound machine, you have to make an effort to learn ultrasound. And you must be clear in your mind what you are doing and what you are learning and what are your limits. So for example, a gynecologist, I don't expect him to know about detailed fetal anomaly scan, but I expect him to know the basic of ultrasound. So ultrasound basic is important for all of us. And in this coming few minutes, I'm going to talking about what are the basic and what you need to know and what you don't need to know at this point. Now, if you use ultrasound at the point of care and you are in the labor room, ultrasound can help you with the basic applications like fetal life, that's heartbeat. That may sound silly, but it is a problem sometimes. If you have a patient like my patient here in Doha with a high BMI and having multiple cesarean section and having liposuction, and then 3 or 4 abdominoplasty. I'm not giving you a imaginary scenario. This is what I see every day. You can get difficulty seeing fetal heart rate. So ultrasound will be very useful. The fetal number, again, it may sound easy, but it can be confusing, especially when it becomes 3 triplets or 4 quadruplets or more. And when we're doing ultrasound, we always count less than the actual number. So I made a mistake in my life in the last 20 years. I remember vividly. There was the patient which I say she was carrying a quadruplets, no, quintuplets, and she ended up carrying 60 plates. So I missed one baby, and that's because she came late. So for the fetal number, you tend to count this number. But I hope if you have a multiple order pregnancy, I hope you have the diagnosis before she come into labor. Maaz, can you hear me clearly? Hiba Ahmed, Rasha Awad, can you hear me?
Yes, yes, we can hear you clear.
Thank you. And then you can assess the fetal position and presentation, and we assess the Likert volume. And then the most important thing probably when we are talking about point of care ultrasound is the placental function and position. The fetal life is just putting your ultrasound and finding out where is the heart located, because you want to put your either CTG or you want to do intermittent auscultation. So you want to make sure where could you put the transducer or where you're going to put your V-heart. So that's the fetal heart rate. It's simple, straightforward. Now, if there is no heartbeat, there will be no heartbeat, but there will be other signs like hydropic changes. Let me just check this again. Yes, like hydropic changes and some feature on the fetus. And I try to put this from my own collections here. And you're going to see these pictures. These pictures you're going to see. You're going to see here, in this picture, you're going to see the fluid in the chest and the abdomen. And you're going to see here also fluid in the head of the baby. And here you're going to see fluid in the abdomen. You can see the lung floating. This is the picture of hydropic baby. So you look at the fetal heart, no heartbeat, look at the baby, you will find other features which confirm that there is no heartbeat. And that is, again, can be very critical from many points of view, from medical point of view, from the medical legal point of view as well. This is feature of absent fetal heart rate and hydropic baby. The fetal number, I said to you just now, it is very important to look for the baby carefully. And in this case, I think probably it's more practical to ask history rather than doing a scan yourself. The patient will tell you whether she's having a single baby or twin pregnancy, unless she has never been seen before. Unless she has never been seen before, then probably there will be a point of doing and making sure that the number of the babies are adequate. These are twins, and you can see two heads. The lie of the baby, is it transverse lie? Is it oblique lie? Is it longitudinal lie? Is it head first? Is it bottom first? Is it shoulder first? And if it is head, is it occipital anterior or occipital posterior? All this information, if you can do it properly, especially the last one, the position, that will help you to monitor the labor. Because if I know that the woman is having primary gravida and she's occipital posterior, then probably I'm going to know that she's going to be in for a long time. And maybe then I will consider epidural. If the baby, on the other hand, she's having occipital anterior, by the way, occipital anterior, occipital posterior ultrasound is quite easy. It's make a diagnosis in less than half a minute if you know what you're doing. So in these things, the lie, the presentation, and the position can be determined very easily with ultrasound. Now, I want you to look at this picture very, very carefully. This is one of the also pictures. Always, 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 when you start scanning, please, the first thing you do, you put your probe and look at the maternal bladder. I'm going to pause for a few seconds. If you're scanning a patient for the first time, my advice to you, even before heart rate, put your probe and find out where is the bladder, where is the maternal bladder, because that will tell you immediately two main information. One, what's the presentation, and two, is the placenta low lying or not. Very simple. I always start scanning of any patient in after second trimester by putting my probe and finding out where is the maternal bladder. Then we are in business. Is it head purse? Is it breech? Is it transverse? Is the placenta here, or there is low lying, or the placenta is not seen? Good news. Is there any cord here? That could be again a surprise finding. So start your examination by putting the probe here and look for the maternal bladder, and then you will immediately see the cervical canal, like this picture. And I'm going to show you more picture. So the maternal bladder is critical. Here's an example. The maternal bladder. You can see here there is a breech. Here the femur. It's not a good slide at all, but that is the idea. Here is the breech here. I should probably put my own. Now, sometimes I said before, you get a cord. You put your scan and you suddenly find the cord. It happened with me before. And then you know you have a rare case of cord presentation. Cord presentation. And maybe vasa previa. So in that case, you're going to save this baby by just putting the probe and trying to find out maternal bladder. Maternal bladder. And this is one of my patients here. You can see I will put the probe and we're first surprised to find the cord in front of the baby's head. There was the head and then the cord. And so there was no way you could have delivered. And if you go into labor, we might have a disaster. So that's quite useful. And this is the same patient with the colored Doppler, but I don't want to go into details about this. Now, the ultrasound is very, very important at point of care to assess the Leica volume, And those who have heard me before, they have seen this video, but I love this video because this video explained to many people what's happening. The fluid, amniotic fluid around the baby come from the urine of the baby and get absorbed by the baby, get taken back by the baby. And it is the equilibrium between passing urine and swallowing the urine is the amount of Leica. So this slide for me is quite important. You can see this is one of my patients here. This young man is having good time. He's passing urine in front of my own eyes. So that's where the Leica come from. When I assess the baby or the fetus or the mother in labor room at the point of care, I want to know, is the Leica volume normal or reduced or excessive? I want to know whether the Leica volume around the baby is adequate, small, or excessive. How do we do that? Do it by two ways. The one which we use every day is the largest vertical pocket. Largest vertical pocket. The other one is called AFI, amniotic fluid index. I will show you both. But for the sake of development, for the sake of your future, when you develop in your career, you're going to use the largest vertical pool rather than AFI. Because most of the papers, when they talk about assessment of the amniotic fluid, they talk about the largest vertical pocket. What does it mean? It means like this. I scan the baby, I scan until I find that place where there is no fetal part and there is no cord. And then I freeze, I stop, and then I make it this one from top to bottom. This is called deepest vertical pool. I will repeat again. What you do, you go around, you do a tour until you come to a place where there is no fetal part and there is no cord, and then you freeze like this. And then you measure it like this one. This is called deepest vertical pool. The normal value is anywhere between 3 or 8. So this is called deepest, largest vertical pocket. Okay? This is the one method. The other method to assess the Leica volume is called AFI, amniotic fluid index. And in that case, you divide the abdomen imaginary lines into 4 quadrants: upper left, upper right, lower left, lower right, and you add them together like this video here, like this case here. So you go in the upper quadrant, right quadrant, upper left quadrant, lower left quadrant, right lower quadrant, and you add them together, and the normal value is between 10 or 8 to 20. But I repeat myself again, the one which we use every day is this one, deepest vertical ball. That's what we use every day. That's what all the labels is about. So to assess the Riker volume, you can use either deepest vertical ball, or you can assess amniotic fluid index, and you have to know the normal values. This is the case of polyhydramnios, and you can see here, I took here the deepest vertical ball here. It's quite obvious that there is a problem with the Riker volume. Is there any question so far? Any question? Okay. If there is no question, I will carry on. And then I think the next piece about the placenta. Now, this is critical because it will affect the mother health and the baby's health. And it can lead to maternal mortality and more severe morbidity. So you have to know how to locate the placenta. And when we talk about placental problems, we are concerned about two conditions only. Central position or location, that is it a brevia or high placenta? And then abruption. So we talk about placenta brevia and placental abruption. Now I like this diagram. Here you can see, this is the normal situated placenta. Here, the placenta is in the lower segment and covering the cervix partially. This one is the lower segment and covering the cervix completely. So this is a complete placenta brevia, this is marginal, and this is normal. So you have to know how the placenta looks like. I always tell people ultrasound is about apprenticeship. You scan every day, you get used to see what you are seeing. What we call pattern recognition. Pattern recognition. What do I mean by this? Who is the best person to scan patient every day? The sonographers. Why sonographers? They are good because they do it every day. Every day they have 20 patients for the last 20 years. So they know what things look like. They may not have the knowledge. What does it mean? But they know this is A, this is B, because they have seen it. And nowadays there is a computer program. People develop a computer program and they give the computer information about, for example, how is CBC look like? How the BSD look like on ultrasound? How is diabetic hernia looks like? And the computer, and you just scan, and the computer will tell you the diagnosis. It's simple because they feed the computers millions of images about the normal diaphragm. So when the diabetic hernia, he will know. But let's go back to our lecture and think about placental location. So it could be either with placenta brevia or abruption. Placenta brevia, let me just be brief. Placenta brevia, the diagnosis and the management depends solely on ultrasound. Placenta brevia, the ultrasound is critical. Placental abruption, ultrasound is the waste of time. We diagnose and manage from A to Z, placenta brevia, relying on ultrasound. Our only reliable diagnostic tool for placenta brevia is ultrasound. Placental abruption is the clinical diagnosis. Ultrasound role is very limited. This is one of my videos which I show it to the student. It's difficult, that's why I show it to you. This is how it looks like. You remember what I told you? You start by showing maternal bladder. This is maternal bladder here. So I know where I am now. Look here. The placenta is in front of the baby, so it's a low-lying placenta. Number two, I can see there is no head, so it's breech. So by doing so, I immediately saw two things. The placenta is low-lying, and it is the pre-presentation. You start your ultrasound examination by locating maternal bladder. The same video, again, just to make the point that here is the maternal bladder, and immediately I could see the placenta, and then I can see there is no head, it is pre-present. That will take a few seconds diagnosis. And that's how it looks like. That's how placenta looks like. Normal placenta look like this. It may be large, it may be small, but that's how it looks like. And there is no way You would know placenta on ultrasound unless you see it once, twice, 3 times, 4 times, and then you recognize this is the placenta. What we call pattern recognition. Pattern recognition. And here again, how is it? It can be difficult. What it can be because there is oligohydramnios. It can be difficult because there's a contraction, and then the myometrium mimic the placenta. It can be difficult because placenta is not anterior like this, but it's posterior. It can be difficult if there is abnormal placenta. There's 2 placentas. There is another loop somewhere else, and it can be difficult if you could not get maternal bladder. So always try to find maternal bladder and try to use the maternal bladder either full or empty to help you to make a diagnosis. I'm going to repeat this again. For you young people, ultrasound is very critical for placenta previa, and one of the enemies of ultrasound is oligohydramnios. If you have, what are the enemies of ultrasound? Is oligohydramnios and high BMI and multiple cesarean section. Make the scan very difficult. And so one of the pitfalls in the scanning placenta, not only placenta, but all the structure of the fetus, is if you have oligohydramnios. If you can sometimes confuse placental myometric contraction with placenta, in that case, just wait. Contraction will go away and you can see. If you cannot see the whole placenta, please look for extra loop. And in that case, color will help you, but that's not very important. But remember what I told you at the beginning of my talk, always start by putting the probe, identifying maternal bladder. This is a simple, just to repeat what I said. This is the placenta here in the lower segment of the uterus, touching the cervix, and here is complete previa, covering the cervix completely. This one may go up with time. This one, there's no chance it will go up. That's what you call minor and major. I don't like this at all. I would just say placenta is a previa or not previa, because the management will be either a normal delivery or cesarean delivery. So I want the sonographer to tell me, is she going to have normal delivery or do I need to take her to theater? And that is what I said just now. You start by seeing maternal bladder, and then you can see the placenta and presenting part. Now I want to tell you something very important, which we have problem in Sudan. Please, and I repeat myself again, if you're going to buy a machine, if you're going to start to work in any hospital or in a private sector or whatever, don't buy any machine without vaginal probe. I look around in Sudan, in Khartoum, and I see a lot of my senior colleagues, they don't have vaginal probe. Trust me, if you don't have a vaginal probe, you are at a big disadvantage. The vaginal probe, it doesn't have to be 3D, 4D. It has to be a vaginal probe. What do I really mean by this? Suppose I want to buy a machine, and the people who are saying, he said to me, okay, Prof, I'm going to give you a good machine with ultrasound, abdominal probe, with color Doppler, Bohr Doppler, and with the stick technology, but the no vaginal probe. And I'll give you another machine with basic applications, but vaginal probe. I will buy the second machine every day, because the vaginal probe is very important. And tell your patient that vaginal probe does not cause bleeding in placenta previa. Vaginal probe does not cause miscarriages. Vaginal probe is a very safe, and it's your best friend. Now, placenta previa, you need to know this. I'm sure you know it. Probably you know it better than me. If you scan women at 20 weeks, at time of the anomaly scan, a lot of women will have flow-like placenta. So we cannot diagnose placenta previa except after 24 weeks of gestation, because at term, it is less than 1%. If you scan them in mid-trimester, it will be about maybe 5%. And in Doha here, I even have to go and so many tell my colleagues that please don't worry patient, because I get almost every day people come to my clinic and crying with the whole family, and they say because she's 20 weeks of gestation, one of our colleagues tell her that she has got placenta previa, placenta is low lying, don't eat, don't drink, don't have sex, don't go out, don't shop. And that is everyday story. Placenta previa diagnosis is made after 24 weeks. Placenta can be low-lying at the beginning of pregnancy and it goes up. This is very normal. It's very normal. And the way I explain to people, imagine you have a balloon. If you have a balloon and you put your name at the beginning of the balloon, put your name like Maaz or Mazin at the beginning of the balloon, and you blow the balloon. The balloon will blow and then the name will go up and up as you continue blowing the balloon. That is what happens. That's what you call migration. That's not migrate, but as it grow up, placenta grows up. So this is a very important point, that placenta previa at term is quite infrequent. Placenta previa or low-lying placenta at 20 weeks is not uncommon. I should not worry your patient. I like this picture again because it just emphasizes what I've been saying. Maternal bladder wall, and then immediately see the placenta, the low-lying placenta. And then we can talk about other things like Akita and Akita, but it is not my topic today. My topic today is just to show you the placenta is low-lying. Abruption, I don't going to waste any time. Ultrasound is very poor in diagnosis of abruption. Abruption is diagnosed on clinical ground. They tell you that you will find fresh blood or clotted blood, forget about it. Abruption is the clinical diagnosis. Placenta previa is relying on ultrasound 100%. This is the case of abruption. I don't believe you need to know even about it. It's not important. Now, this is a very important part of the lecture. Cervical assessment. Cervical assessment. Does anybody have any question before I proceed? Any question? Give you a few minutes, 2 or 3 minutes to ask any question. Please don't be shy. It's an opportunity to ask any question. Yes, go ahead. وعليكم السلام.
السلام عليكم.
هبة؟
بسأل يا أيوة
تفضل.
أنا دكتورة أسماء.
أنا أسمع.
بسأل.
Sorry?
How to differentiate between the placenta والmyometrial contraction. مرات بتكون.
Yeah, the question is how you differentiate between placenta previa
myometrial contraction مثلا ولا myometrial.
and myometrial contraction. This is a very good question. Time. As an old man, I put my hands to feel the contractions. But even if you cannot do that, just wait for a few seconds. Go and do something else. Go and do measurement. Go and do something else and come back. If it is a contraction, it will disappear. So don't waste your time. Just leave it and go and do something else. That will come with experience. But if you are going to talk worried about it, just give it some time. Contraction will not last forever. It will go away. But in my book, I don't think that's a big problem, because with experience, your eye will get used to the placenta and then you can pick it up very easy, even if you are half asleep. But good question. Thank you, Asma.
Hello. Hello.
Yes. سامعك. تفضل ماما.
Yes, yes, boss. Thank you. I want to ask how, yes, Insaf, how we can differentiate between the placenta and clot. For example, in case of abruption placenta or like this.
The clot will be behind placenta. But I'm going to tell you again, I repeat myself, do not at all rely on ultrasound to diagnose abruption. At all. Unless it happened a long time ago, it was a mild abruption, then there will be a degree of calcification of the clots and you can see it. Apart from this, I'm telling you after 30 years of experience, abruption is not an ultrasound issue. Abruption is a clinical diagnosis. Okay. I'm gonna move on to the next part of the lecture. Is cervical assessment, which is extremely important. One of the most important development, in my view, in the last 20 years or so, has been vaginal ultrasound and vaginal probe. This is the one which I use every day. Be lucky because this is a vaginal probe with 3D, 4D capability. And I'm not going to go out now from the lecture. I'm just tell you for the future, because you are all about to start your career or you are just starting your career, having a vaginal probe, and if you can have vaginal probe with 3D, 4D, then you are in business. Because with the vaginal probe with the 3D, you scan the uterus for exactly 10 seconds. You scan the uterus in 10 seconds, and then you freeze, you get the volume, you have everything in the volume, which you obtain in 10 seconds. Hopefully one day I'll be able to give a lecture about vaginal scan. But today, you do the scan for cervical length. And look at this video. This is not from, this is from my own videos. You can see here, so clear. This is the intrauterine cavity. This is the cervix. This is the anterior lip of cervix. This is the posterior lip of cervix. And here's the cervical canal here, this way, from here to here. So I can see internal os, canal, external os, anterior lip and posterior lip. It is so easy and so clear that you cannot make a mistake. You need only one day with experienced patient to show you how you do cervical length assessment. If you know how to do cervical length assessment, then you will not do cervical circulage, because you'll find a healthy cervix and the cervix which does not need anything to be done, and you can escape giving circulage. Also, if you can do vaginal scan properly and you can assess cervical properly, you know when there's a problem, when there's shortening, when there's effacement, when there's herniation of the membrane, and everything. I'm going to show you in a minute. So, cervical length assessment by ultrasound is very fantastic. I'm showing the video again because I want you to have this picture in your mind. Keep the picture in your mind. I'm doing vaginal scan. This is live scanning. This is the cervix here, anterior lip. This is posterior lip. This is the cavity inside. This is the baby here. You can see the limbs. But this internal os very clearly seen, the canal and the posterior os. Very clear. Assessment of cervical length using transvaginal ultrasound. So you're going to evaluate the length of the cervix, whether it's dilated or not dilated, effaced or not effaced, and whether there's the membranes bulging. I'll show you some example. Here you go. This cervix is short because this part is lost. So you can see here, there's only left in this part from here to here. This part is lost because the membrane herniates inside the cervix. Okay? Look at this video. It's even worse. There is almost no cervix. The cervix is finished. There's no cervix. You are about here going to the vagina because there's a herniation of the membrane. And that is done within few seconds. Another video, you can see here, I've lost cervical length completely. If you see this patient, she's going to deliver very soon because there is no cervical canal. Cervix is completely lost. You start from here, from this cervix, this cervical here, where you have the full length of the cervix, and then you come here, you lost half of it, and then you come here, you lost the whole cervix. So you can evaluate the cervical canal, cervical length, cervical dilatation, cervical effacement in few seconds. Few seconds. By the way, this is what we call a sludge, which is the material inside the cavity indicating strongly the presence of intra-amniotic infection. It's called a sludge. It's not your problem, just for you to know. Now, fetal biometry. One of the most important functions of the ultrasound in modern obstetrics is fetal biometry. And by fetal biometry, we can decide the age of the pregnancy. Fetal biometry to decide the pregnancy age. But also fetal biometry is very important for the anatomy. For the age of the pregnancy, in the first trimester, we rely on crown rump length. If you get this picture of the baby at 12 weeks, if the mother does not know even her period at all, you don't need her period because these are very accurate dating. You may get the crown rump length, CRL, and you go to the book and find how many weeks, and then you can tell her, Mom, you are now 12 weeks pregnant. End of the story. If she tells you she have 4 months, 6 months, just ignore her. So what do is crown rump length. Now, if we see the patient in the second and third trimester, we have to measure other things like the head circumference, biparietal diameter, abdominal circumference, female length. And these are the parameters to help you to estimate the baby's weight and the baby's age, which are BBD, head circumference, abdominal circumference, and female length. These are important to determine the age of the pregnancy and also will help you to determine some pathology like skeletal malformation. Skeletal malformation. If a patient have a series imperfecta, you will find the bone broken. If the patient have chondrodysplasia, you will find the bone is short and indented and so on and so forth. But the main function of fetal biometry is to determine the age of the pregnancy. I'm going to repeat the last point about this. In the first trimester, the pregnancy age is determined by measuring the crown rump length. Crown rump length is very, very accurate in the first trimester. Very, very accurate. In second trimester, we rely on the BBD, head circumference, abdominal circumference, and female length. This is what you do in the second trimester to determine the age of the pregnancy. Third trimester, forget it. You cannot determine the age of the pregnancy in the third trimester because you can talk about plus or minus 3 weeks. So if you see the patient for the first time in the third trimester, you cannot determine the age of pregnancy accurately. All what you can do is measure everything I told you and then see her back after 2 weeks and see the progress. If you are desperate, you can use the femur. It may give you a clue. Or you can measure the transcerebellar diameter. But the accurate measurement of the age of the pregnancy can be done only in the first trimester, relying on crown rump length, like this picture. Crown rump length. That's why I always say to my colleague, if you have a high-risk patient, send them to FMU, or fetal medicine unit, only twice. One at 20 weeks and one at 12 weeks. And that's it. Then you can keep your patient. Because at 12 weeks, I do a pro assessment and I finish my assessment at 20 weeks, and that's it. The rest can be done at any other clinic. Okay? Any question before we think about surveillance? Any other question? Please don't be shy. If you have any question, I'm quite happy to stop and help you because I'm here just to help you.
Shaiba, welcome. Shaiba, ask.
Alaikum salam.
أنا بسأل if a cervix thickness disappear, that mean it is a case found.
Is it a case of what?
If a cervix thickness disappear.
Yes, like this one. Yes.
Yes, that means it is a phase.
Yeah, it is fully effaced. There is no cervix. It's taken up completely. This woman is in labor, in advanced labor, and hopefully she'll be term because there is no cervix. Look, compare it to this one. Always compare it to the normal one. This is the normal cervix. Close, long cervix, like this one. So this is the long, closed anterior lip and posterior lip are opposed together, and this is a closed cervix. And if you compare to other cervix, you can see the difference, huge difference in cervical appearance between the
very interesting.
Yep.
For me, thank you.
Thank you. Now, fetal anatomy survey.
Hello?
Yep.
Yes, boss. What is the purpose? Can you hear me?
I can hear you very clearly.
Yes. What is the purpose to do cervical ultrasound assessment, I mean, in the third trimester? Why we are doing? In my mind, we have to do it in the early second trimester, for example, in case of incompetent tonsor like this. But why I have to do cervical assessment for the patient in third trimester?
We don't do it at all unless there is an indication. Let me give you an example. If the woman came to you with vaginal bleeding and there's a suspicion of placenta previa, and you want to, is it the placenta previa complete or incomplete? cervical assessment by vaginal scan will give you an answer immediately. If a woman came to you with vaginal bleeding and there is suspicion that it could be from the fetus, it could be a cold prolapse and vas brevia, then that question has been answered. But routinely, I don't do cervical length assessment in third trimester at all routinely. I do it routinely, even in the second trimester, not routine. It's done only if there's a history of preterm labor or the history of late miscarriage. Although, having said that, there is now a big call to do for all women assessment at 20 weeks to protect against preterm labor. So there is a lot of people now calling that all patients should have cervical length assessment at 20 weeks scan to cover against possibility of short cervix and preterm labor. But that is debatable. But answer, it's a good question. We don't do routinely cervical assessment in third trimester. Not routinely.
Okay, thank you.
Thank you. Now, fetal anatomy survey, and I don't agree with also, you don't need to know this at all, unless you become specialized in fetal medicine. But what is the idea? The idea is that ultrasound could be able to assess the anatomy of the baby. And this is a slide which I show all the time. If you want to say the baby is normal, please don't kid yourself. Don't lie to yourself. If you write in your report at 20 weeks, you know, if I write in your report at 20 weeks, the baby is normal. For me, as a fetal medicine person, I understand that you have done all that. You have done the skull, you have seen cerebellum, you have seen sternum magna, you have seen anterior horn, posterior horn, you have seen the upper lips and the lower lips, you have seen the spine, you have seen the diaphragm, you have seen the two kidneys, you have seen the cord insertion, you have seen the heart, the fourth chamber of the heart, you have seen the pulmonary artery, you have seen the aorta, you have seen the right limb, the left limb, and I can tell you, nobody does that. So please don't kid yourself and say the fetus is normal, which you all do, and it's not true. You had to tell your patient what you have been done. I tell her, Mom, I've scanned the baby, looks okay, no problem, heartbeat is okay, but this is not a fetal surveillance. A fetal surveillance will require basic treatment, basic training, what we call baseline anomaly scan. It cannot be done by everybody. It has to be trained. This is level 2 ultrasound. This is not level 1. So also, you require to do level 1, not level 2. You do level 2, that's another issue altogether. I hope my point is clear. Now, twins, pregnancy, triplets, quadruplets, quintuplets. What is to do is also, for also point of view, I want to establish the number. I hope you know before she comes to you whether she is twins or not. I hope you don't have to do that in labor, although it does happen. It happened to me in Newcastle. When in the early days of my days in Newcastle, I was in the labor room. I came from Sudan straight to Newcastle on call, a new registrar in the labor room. The woman delivered her first baby, and I was there. And then I said the abdomen. I said to them the second baby, and then they all look at me funny. This African man is talking rubbish. What a second baby. Then a few minutes later, the baby delivered. I'm talking about Newcastle upon Tyne in UK, not in Sudan. That was about 25 years ago, something like that. But the point is, twins was missed before ultrasound. Twins were diagnosed in labor, in many times in Central Europe. So for the sake of also, you have to make sure the number is right. So the twin pregnancy. Now, for twins pregnancy, I want you to remember that the ultrasound for twins pregnancy in labor, as far as also is concerned, is about the management of the second twin. So it's about intrapartum care. Intrapartum care. So ultrasound with regard to this is management of second twin. First baby delivered, second baby, you put your probe in, look at the second baby. Heartbeat, liquid volume, presentation, position, second twin. But I want you to know, before you leave this course, that there is nowadays nothing called twins pregnancy. Can you all hear me very clearly? Yes?
Yeah, bro.
Yes.
Yes.
There is nothing called twin pregnancy. There is either monochorionic twin pregnancy or dichorionic twin pregnancy. There is nothing called twin pregnancy. There's any report, I get any report from a doctor who said twin pregnancy and doesn't, I don't read the rest of the report. It's not worth reading. You have to specify, is it monochorionic or dichorionic? Dichorionic means lambda sign, like this one. There is a membrane here and the lambda sign. This is dichorionic, like this one. You can scan here. You can see that there is a lambda sign here. This is the dividing membrane thick one, and there's a lambda sign here. This is called dichorionic, or it could be monochorionic, like this one here. There is a T sign. This has to be very clear in your mind. In twin pregnancy, I want to know a big question. Is it monochorionic or is it dichorionic? Because the difference is like day and night. Monochorionic twin pregnancy is the very highest pregnancy compared to dichorionic twin pregnancy. And the only time you can make a diagnosis, 100%, is in the first trimester. Diagnosis of twin and chronicity is 100%, whether they're mono or di, 100% in the first trimester. Are you with me or have I lost you? Are you with me? Fantastic. So this is monochorionic, T sign. This is dichorionic, lambda sign. This is critical. This is very high risk pregnancy. This is less risk pregnancy. And that can be made only in the first trimester. Diagnosis accuracy is 100%. Please go home today and remember that. Just tell everyone that Professor Badruddin is saying from today, there is nothing called twin pregnancy. You have to tell me whether they're monochorionic or dichorionic. End of the story. Because there are two different conditions. Another point which I want you also to know, although it's not an also, but it's very important in your career, something called vanishing twin syndrome. Vanishing twin syndrome. If you see a twin at 10 weeks, please don't tell the woman she's going to have two babies, because it's not true. About 20% of twins, they disappear. It's called vanishing twin syndrome. Vanishing twin syndrome. And I'm going to tell you a story because it's a landmark story. So please bear with me. I remember when I was in Khartoum, I was a lecturer in Khartoum University, and I went to learn ultrasound in Hungary. And because I was a young man and I was not very wise and not clever enough, no experience, I was scanning everybody in Khartoum. Everybody sent me a I scanned them. I was scanning every day. So I saw a patient, and she was, I think it's about 8 weeks. And of course, because I was very naive, I told her, you're having twin pregnancy. Be happy, enjoy it. She didn't come back to see me again at all. I heard the story about 5 years later. This woman, which I diagnosed twins, she went, I want not tell you which hospital because you know the people. And then the chap there, one of my teachers, which I respect and I love, and I'm sure he loves me as well, saw her. And this man does not like ultrasound at all. He saw her when she was 7, 8 weeks. So of course he examined her, said that you're having one baby. She said to me, Professor Badruddin, not Professor Badruddin, Badruddin told me many months ago that I got twins. فقال لها الله يعرف عن بدر الدين ذاته فمهم شتمني because he's just like my father. He was making a joke about this in the country for about 2 or 3 years. You know, ultrasound is rubbish, and they tell people rubbish, they don't know anything. Because at that time, nobody knows something called vanishing twin syndrome. We now realize that about 20% of those who are twins, they disappear. It's called vanishing twin syndrome. So this man is still alive, and I love him, and I didn't tell him the story at all. But one of the lectures I told him about the vanishing syndrome, of course he didn't remember. But my friend told me that when I was in UK, that this man is making joke about you every day. Because he likes me, that's why he makes jokes about me. So for the twins pregnancy, and also management of ultrasound is only for the management of the second twin. So the ultrasound is used to manage the second twin. First twin is delivered, you need the ultrasound to manage the second twin. That's why when in our protocol here in Doha, in the labor room, if there is a twin in any of the rooms, then ultrasound has to be in the room. Because when the baby is delivered, you put ultrasound to see what is the presentation of the second twin, the heartbeat, the liker, and everything. So it's critical for second twin. Now, ultrasound can help you in procedures, and that is very quick. Two things ultrasound can help you with is one is external cephalic version, and the other one is amniocentesis. So with ultrasound, you can do amniocentesis. You can see one of my brain here. You can see I'm trying to enter here, pressing, and I can see the needle all the way. You cannot do amniocentesis without seeing the needle from top to bottom. You can see the needle here, coming here. And that's why when I was in Newcastle, by the way, Newcastle, we used to do amniocentesis without ultrasound. No, they go to the ultrasound department, they put a point, and we go to that point. But by the time the patient moves from the ultrasound room to your room, the baby will have moved 100 times. Nowadays, we do ultrasound amniocentesis, and we see the needle all the way through. And that's why when people tell me that the incidence of complication with amniocentesis is 1 in 100, this is rubbish. This is not true. The chance of miscarriage with amniocentesis is less than 1 in 500, because we see exactly what you are doing. You can see here, I'm seeing my needle all the way. So there is no way you can do any damage, and it is very safe. So one of the things you need for ultrasound is doing amniocentesis. Okay? The other procedure is external cephalic version. This is very important, especially in Sudan, because we try to avoid cesarean section. If you have multi-gravid patient, pre-presentation at term, please do your best to do external cephalic version and use ultrasound. It can be done. If you get used to it, you can do it without any complications. External cephalic version. So the two procedures which you need ultrasound for the sake of also external cephalic version and amniocentesis. Now I come to the end of my talk, and I will summarize by saying you have to answer some questions with ultrasound, like fetal heart rate, number, fluid assessment, placenta localization, whether it's a brevia or high. Abruption cannot be done by ultrasound. Brevia can be dealt with ultrasound. Ultrasound is not good in abruption. Transvaginal ultrasound is a tool which you should use all the time. Transperineal ultrasound is very rarely used. So the two things you need to know is transabdominal ultrasound and transvaginal ultrasound. And I would like to stop here, and I would love to answer your questions if you have any. Shukran.
Thank you very much, Professor. محاضرة.
شكرا.
Any question? Please ask any question. You remember famous say there is no wrong question. There can only be wrong answer.
شكرا بروف بدر الدين، جزاك الله خير، وسعيدين انه كنت معنا.
والله انا اسعد يا ماما، انا اسعد بكم والله. اتمنى كنت اكون معكم ان شاء الله، وان شاء الله يكون معكم ان شاء الله.
عايزين لكشر، الناس مبسوطه، حاسين ده والدلمين بغني ولا حاجه زي كده.
لا انا لا الله يخليك، خيرك على الكم. انا I enjoy being especially يعني.
خلاص جاي الكورس في السودان يا بروف.
نعم
بروفيسور دكتور امير داير يسلم عليك، امير عثمان موجود معنا.
اهلا بك، اهلا امير. اهلا يا امير، كيف حالك؟
الحمد لله، كيف الصحة والأحوال؟ إن شاء الله كويس تمام؟
الحمد لله، أنا والله سعيد بكم، وإن نلتقي قريب إن شاء الله. ربنا يدينا الصحة والعافية إن شاء الله، ونشوفكم كلكم إن شاء الله بخير إن شاء الله.
إن شاء الله إن شاء الله، شكرا جزيلا ما قصرت. إن شاء الله نتلاقى. الله يبارك فيك. الله يبارك.
أوكي، شكرا يا جماعه. Thank you so much.
شكرا يا بروفيسور، شكرا يا بروف، فرصه سعيده.
موفقين ان شاء الله، موفقين ان شاء الله.
الله يكرمك، كتر خيرك. ثانك يو فيري
مع
ماتش.
السلامه. مع السلامه. مع السلامه.
الله يسلمك. سلام. شكرا جزيلا بروفيسور بدر الدين على المحاضره القيمه، ودائما قلت لكم انتم لكي والله محظوظين جدا يا شباب، وتستاهلوا عدنياتكم يعني. المحاضره الجايه برضو من المحاضرات المهمه.
لو سمحت ممكن تدينا 10 مينت للصلاة؟
للصلاة. أيوة الصلاة يا
10 مينت.
دكتور.
دكتور امير معلش نستاذنك لانه احنا شغالين من قبل، ناخذ لنا 10 دقائق، الناس حنكون فاتحين بس نصلي ونجي راجعين ثاني.
جدا ما في مشكله. تمام.
تمام. ثانك يو فيري ماتش. ثانك يو.
يلا ويلكم.
خلينا معاكم يا شباب، ربنا يتقبل.
دكتور معاذ ازيك يا رب دايما بخير ويديك الصحه. في واحد انا كنت قعدت في كذا مره واشتكيت وقلت ان ما ينفعش ان هو خلاص هيخلص في شهر جولاي. ازاي هو المفروض they have never received the ISWAP membership والسودانيز دكتورز are very upset ودفعوا بعت لهم الريسيت بيمنت بتاعت الى ار ال 187 بريتش باوندز استرليني المفروض قصدي 178 دكتورز. فرد عليا واحد اسمه اندريا اول مره يعني يعمل عشان صعبت الموضوع وجبتهم بالتليفون رغم ان ما فيش حد بقى في المكتب خالص كلهم بيشتغلوا من البيوت. المهم بعت لي يقول ان هو سوري وان هو هيعمل لهم الممبرشيب وبعت لي السيرتيفيكت دي اكد ان هم دول الدكاتره. وانا طلبت من ساعه ما يعمل لهم السيرتيفيكت ان هي تبقى exceptionally for this exceptional situation يعني تبقى valid for 1 year certificates وممبرشيبس. ربنا معاك دكتور معاذ الغالي ونشوفك يا رب على خير ودايما بخير. ويعني هم مهتمين وان شاء الله هم اللي بعتوا لي الليست دي تاني. انا كنت بعتها لهم بعتوها لي يقولوا لي هي دي الليست ولا ايه، فراجعتها وراجعت البيمنت الريسيت وعديتهم بنفسي لقيتهم 178 استرليني ل 178 دكتورز. وبعت لحضرتك الاسبوع. ربنا معاك يوم جميل دايما بخير يا رب ونشوفك على خير. تحياتي البالغه. ربنا معاك. سلام. يريد.
بس لك رسالة فضل. اسمع. اسمع.
Recording in progress. Recording in progress.
طيب مرحبا بك دكتور أمير عثمان. أمير نحن جاهزين عشان نسمع المحاضرة بتاعت المال برزنتيشن مال بوزيشن. دكتور أمير كونسلتنت أوف شانغاي وهو ستاف جامعة الخرطوم مستشفى سوبا سعد أبو العلا also instructor من الرعيل الأول بتاع. مرحبا بك يا دكتور أمير، وفرصة طيبة وفرصة سعيدة إنك كنت تكون ختام البرنامج بتاع الأونلاين. ده آخر لنا محاضرة يا شباب، المال برزنتيشن مال بوزيشن. تفضل يا دكتور أمير، المايك معاك. شكرا جزيلا.
طيب السلام عليكم. I am Amir Osman, also an instructor. I'm happy to have you today. We are going to talk about malpresentation, malposition, and multiple gestation. معاذ الشاشة حقتي ما ظاهرة. الو معاذ سامعني؟
دكتور اعمل شير سكرين، اعمل شير للسكرين. دكتور امير اعمل شير للسكرين. يا جماعه نعمل ميوت لو سمحتوا. دكتور امير
السكرين حقتي
يعمل لها شير. ولا شير
طيب.
انا؟
لا اعمل شير منك انت يا معاذ.
ثواني يكون. كده واضحه يا شباب؟
يا معاذ ما في حاجة ظاهرة في سلايد.
كده ما واضحه؟
لا ما في أي حاجة ظاهرة.
ظاهرة صورتك بس يا معاذ.
حاضر.
معاذ بتجيب في نفسك، شايفينك وعارفينك. جيب لنا البرزنتيشن.
لا ما ممكن اكون بجيب في نفسي لانه الكاميرا مقفوله يعني.
طيب صورتك يا معاذ ما اختلفنا، صورتك.
طيب
كده واضحه؟
كده واضحة.
تمام.
طيب السلام عليكم. أنا دكتور أمير عثمان. زي ما قلنا I'm starting to talk about malpresentation, malposition, and multiple gestation. The objective of this lecture is to define 6 types of malpresentation. We're going to come across them all. We have to list complications associated with various malpresentation. We have to discuss the criteria for selection and management of vaginal delivery with malpresentation. And we are going to discuss also the delivery and management of multiple pregnancy. And we have to list the steps to safely performing delivery of various malpresentations. These are the objectives of our lecture today. We have to, before we start, we have to come across some definitions. Next slide, Ahmad. Muaz, next slide. Yes. بعد objective. Next. Thank you. Lie. A definition of lie is the relationship of the long axis of the fetus to that of the mother. And we all know that there is a longitudinal lie, the commonest. Sometimes the baby could be transverse or oblique when the head is on one of the iliac fossa, right or left. As for the presentation is defined as the lowest fetal part to the maternal pelvis. Just that simple. And the commonest presentation or the most normal presentation is the vertex, followed by bridge, sometimes face, brow, shoulders. These are the different types of presentation. Position is referring to a reference point on the presenting part. Yani when it's a vertex, we're taking the occiput as a reference point. Then this reference point in relation to the four quadrants of the pelvis. Yani occiput anterior, occiput posterior. When it's a bridge, we're talking about sacrum as a reference point. Then we're talking about sacro anterior and sacro posterior. How we diagnose malpresentation? Commonest is Liouvard maneuver, اللي هو abdominal examination اللي بنعملها when we were 6-year students. Okay, fundal height, fundal level, first pelvic grip, second pelvic grip, abdominal palpation. When the membrane ruptures, vaginal examination. When we do vaginal examination, we are going to palpate where is the denominator, اللي هو the reference point. Here we talk about, we can palpate where is the occiput, where is the sagittal suture, then we know it's an occiput anterior, occiput posterior, or sacro anterior, or sacro posterior. The last method we use, sometimes an ultrasound. And now it's becoming available, زي ما قال بروف بترتين قبل شوية, and it's getting a very common diagnostic tool. Rarely on examination, we can't see a flat abdomen for occiput posterior. I mean, the baby يكون the spine lying on the spine of the mother, the lower part, اللي هو below the umbilicus, become very flat. We could rarely find that. Then usually this is confirming or suggesting most likely we're having an occiput posterior. يا جماعة كلامي واضح? Can you hear me?
Yes.
Thank you. The second thing we talk about asynclitism. اللي هو asynclitism is lateral flexion of the fetal head. يعني نحن talk about flexion and extension. I mean, when the chin is touching the chest, that's complete flexion in a vertex. I mean, يكون face, we're talking about extension or hyperextension. Asynclitism when the head is rotated to one of the shoulders, right or left. Okay, يعني the sagittal suture is not in the midline. يعني one of the parietal bone is leading and the other is recessing. Asynclitism is normally in a small degree. لكن لما يكون so big or extreme asynclitism, it can lead to dystocia. طبعا you have, when you talk about instrumental delivery, لو متذكرين في حاجة بيتكلم عن position for safety. When you talk about forceps, usually we have to make sure the sagittal suture is in the midline between the two blades. making sure that we don't have an asynclitism. يعني لما يكون الساجيتال suture is near to one blade, then we're talking about asynclitism. The common occipitoposterior position is one of the commonest malpresentations. And usually people talking about back labor. And usually they come with lower back egg. And usually when they start progressing in labor, we find that there is an anterior lip always persistent. And the cervix start to get dilated on the other part, but the anterior lip of the cervix is still persistent, just like a cap on the fetal head. And usually why occipitoposterior is positioned? Because there is an increased risk of like 10 or 5 to 10 times of operative vaginal delivery. Sorry, 5 to 10 times cesarean section and 6 to 11 times vaginal cesarean delivery. Okay. And usually how we diagnose occipitoposterior, usually for the occipitoposterior, when it happens, the occiput fall in the hollow of the sacrum. النتيجة شنو؟ بيحصل extension of the fetal head. حصل extension نحن when the head is fully flexed we are going to feel only the posterior fontanelle اللي هو in the vertex. When the fetal head starts to extend, you're going to feel the anterior fontanelle. Okay, sometimes it's difficult to palpate the anterior fontanelle because of cabuto everything. Then we can know it's an occipito-posterior or anterior by palpating the curvature of the ear. We know that the curvature of the ear is pointing to the occipito of the fetal head. Clear? واضح يا جماعة؟
Clear.
If you have any question, just you can stop. Okay. Type. That's what we're talking about here when we talk about that's an occipito-posterior. And if you see that the fetal head fall on the hollow of the sacrum, and then you can feel the anterior fontanelle easily because there is some degree of extension of the fetal head. Okay, next slide, please. Type. We can diagnose occipito-posterior or occipito-anterior by using an ultrasound. الصورة الأولى المعمولة A, you can see the orbit of the fetal head facing upward لأنه الحتة البلاك الفوق دي over the image is the urinary bladder. You can see the nose and the both orbits of the baby. That's an occipito-posterior because the face is pointing upward. Okay, as for B, the baby is on the left occipito-posterior. That's the occipit is on the back. This is the, you can see one orbit of the baby facing to the left side of the mother. Okay, again, the image C, you can see cerebellum on the right side of the mother. Okay, telling you that's an occipito transverse. Okay, the image D, you can see the fetal spine upward. Okay, then it's telling you that that's an occipito anterior. Okay, then we can know the position using an ultrasound in addition to doing Liebert maneuvers for physical examination. How we manage occipito-posterior? Sometimes we can, occipito-posterior can be delivered vaginally. And what we can do is we need to flex the fetal head. زي ما أنا قلت قبل شوية, occipito-posterior, the fetal skull fall in the hollow of the sacrum. Then we are going to have extension. Extension معناها greater diameter of the presenting part. We know that fully flexed fetal head has the smallest diameter. Okay, then when we need to deliver vaginally, we need to reduce diameter by flexing the fetal head. Then we place our hand on the hollow of the sacrum behind the occiput. بعد ذاك نحن we see if it occipito-posterior, right occipito-posterior or left occipito-posterior. Right occipito-posterior, you insert your right hand and you rotate to the right side. Okay, left occipito-posterior, you insert your left hand and you rotate to the left side. Okay, and you need to rotate. Clear? واضحة الحتة دي يا جماعة؟
Yes, clear.
Hello? Type. Sometimes you can use a vacuum extractor to deliver. تمام، ممتاز. Vacuum extractor can be used. And usually, sometimes we use metallic cup rather than plastic cup. Okay. The most important point when you use a vacuum extractor, we have to put it on the flexion point. قبل أنا حاضر الدكتور صديق لما ندرسكم الانسترومنتال delivery. The flexion point is the most important because if you put it on the right plane, if you pull, you are going to flex the fetal. يعني لما تحطه on the flexion point over the occiput. But if you put it anteriorly over the anterior fontanelle and you push, you're going to cause more extension of the fetal head, then greater diameter of the presenting part, you end up with having obstruction of the delivery. Okay, if a vacuum extractor can be used for occipito-posterior delivery. Or sometimes we can use forceps to deliver occipito-posterior. Again, when you pull outward and downward, the point is to promote flexion of the fetal head. Okay, Remember always fully flexed fetal head, it means that the smallest diameter, اللي هو sub-occipito-pragmatic diameter, is expected to be around 9.5 centimeters. Any question about occipito-posterior position? Type. No question, means that's clear. The second malpresentation, I'll talk about breech. And it's a very common malpresentation. It's take around 3 to 5% of all deliveries are going to present by breech. We have different types. Frank, the one on the left. Then complete breech, when we have flex hip, flex knee. Footling, when one of the feet below the presenting parts. These are the three types of breech. Number one risk factor for breech presentation is prematurity. Okay, high parity is a second risk factor because of laxity of the abdominal wall, loss of tone of the anterior abdominal muscles. Uterine anomalies like fibroids, like uterine septum, usually the fetal head cannot find a time to rotate. Pelvic tumors, polyhydramnias and oligohydramnias, both of them are risk factor for. نعم. صوتك ما واضح، معلش تاني. Yes. What's your question?
دكتور أمير اوكي دكتور أمير.
تمام. Polyhydramnias, and it's very difficult to for the fetal head to rotate to cephalic. The same oligohydramnias, it cannot rotate back to come cephalic. Fetal anomalies, إذا كان في hydrocephalus, إذا كان في reduced fetal tone, then it's a risk factor for malpresentation breech. If you have cephalopelvic disproportion, اللي هو feet, small pelvis and big baby, then usually the risk factor. Placenta previa طبعا is a risk factor. Having previous breech delivery is a risk factor for current baby to be breech. Usually, antenatally for a woman having a breech presentation, we don't need to worry about it till she reach term. يعني قبل ما تصل 36, 37 weeks, you don't need to do anything for breech presentation. We talk about prenatal management. Next slide, yeah. Okay. Then next. Thank you. طيب, we need to find a cause. اللي هو قلنا الكوز either reduced liquor or excessive increased liquor, fetal anomaly, uterine anomalies, okay, placenta previa. That's why we have to check why the baby is persisting breech at term. Then, if we find that there is no cause that we can correct, then we consider maternal positioning, اللي هو like knee chest position or Trendelenburg, but there is no evidence that suggests that it's useful. But it still is something that a woman could do that might help. Okay, but the most important thing at term, we have to attempt external cephalic version. And every woman who come with breech presentation at term, we have to give her the chance of external cephalic version. If you don't know how to do external cephalic version, you can't send her to somebody who can do it. If she refused external cephalic version, or you tried external cephalic version but it failed, then we have to consider vaginal breech delivery as an option. يعني الفكرة بتاعت إنه breech presentation is for cesarean section, usually you have to abandon. خاصة في situation like what we have in Sudan. We have high parity. Sometimes hospital is not accessible for women. They might rupture their uterus, or they end up with having morbidly adherent placenta or recurrent cesarean delivery. That's why we have to do our best to make sure that either we give them the chance of external cephalic version, or still we can give the option of vaginal breech delivery is a valid one. That's next slide. That's a knee chest position. اللي هو deep Trendelenburg, اللي هو she lift up her hip upward. Usually these are said to could be helpful in changing breech presentation to cephalic, but as I mentioned that there is no evidence to support this. But at least I mention again, we can't just tell the woman that there is a chance of getting that type. External cephalic version, There are some factors associated with success of external cephalic version. High parity. Because of reduced tone, the term high parity is a risk factor for breech delivery, breech presentation. Again, is a risk factor for successful external cephalic version. But for example, if she's a primary gravida, she has increased tone of the anterior abdominal wall, usually rotation is going to be a bit difficult. Again, normal or increased amniotic fluid is also with success. About reduced liquor, usually rotation is might be difficult. Polyhydramnios again is a risk factor that make external cephalic version difficult. Relaxed uterus, as associated with parity. Gestational age less than 6
الصوت يا دكتور أمير. دكتور أمير.
طبعا frank breech usually is difficult because the extended legs act like an splint to prevent rotation. Tocolysis اللي هو to relax the uterine wall اللي هو usually sometimes people give it to make rotation of the fetal body easier. Or sometimes acoustic stimulation for the baby to make him that his mobility or to make him resilient to rotation. Type contraindication. Any indication or contraindication for vaginal delivery is a contraindication for external cephalic version. أو إذا كان عندها أي indication for cesarean section, that's a contraindication for vaginal breech delivery. If you had unexplained antepartum hemorrhage, is a contraindication to go for vaginal delivery. طبعا if she's having multiple pregnancies, it's not practical to go for external cephalic version. Okay, next slide. Next. Right. Yes. Type. No, القبلة. طيب relative contraindication إذا كان عندها preeclampsia, oligohydramnios, abnormal fetal heart rate, uterine anomalies, usually these sometimes it's a relative contraindication. يعني if somebody is expert in doing it, he can still go for it. It's not an absolute. طيب what are the complications of external cephalic version? Fetal bradycardia, and usually sometimes transient, يعني بتحصل له deceleration بعد external cephalic version, and self-limiting, and usually they can stop. طبعا placental abruption is common when we are rotating the baby. Sometimes the placenta could separate, membrane could rupture, fetal maternal hemorrhage, common, fetal injury, maternal abdominal bruising. Okay, sometimes there is increased risk of emergency cesarean section. إذا كان حصل لها abruption or fetal distress after external cephalic version, then we have to go for emergency section. That's why external cephalic version should be done at term, because even if complication happen, we are going to deliver a term baby. How to perform external cephalic version? Number one, we need to elevate the breech. And if it's engaged, then we disengage the breech. And usually you have to push the fetal head forward, and toward flexion. And the fetal head is going to be rotated towards his face, not towards his back. And we need to reduce the diameter between the fetal buttocks to fetal head. And crown ram length is supposed to be shorter. It could be shorter by flexing the fetal head. Okay, that's why if we need to flex him, then we have to rotate him towards his face. Okay, when he becomes transverse, we have to do an ultrasound to see that there is no evidence of fetal distress, no fetal heart. Next slide. Okay, and then once the fetal head passes the transverse position, then usually little effort is needed to bring him to vertex. خلاص لأنه أصلاً resistance اللي هو the narrowest diameter is the transverse of the uterus. Once he passes the transverse, then he could easily, we don't need too much effort to bring him to vertex presentation or to cephalic presentation. Type. Next slide. Contraindication to vaginal breech delivery. اللي هو still, we said that it's always advisable to give them the chance of vaginal breech delivery, لكن that's not unconditional. يعني ما من غير شرط. في شروط لازم تتوفر عشان نحن نديهم chance of vaginal breech delivery. واحدة منهم small pelvis. يعني cephalopolyp big disproportion or big baby. That's why most unit a primary gravida breech, if they didn't give her a chance of vaginal breech delivery, they adjusted the pelvis before. Severe prematurity, because vaginal delivery is associated with risk. Intrauterine growth restriction, placental insufficiency, because already there is a chance of abruption. Then usually the baby is already compromised, then it's not advisable to give them the chance of vaginal breech delivery. Footling breech, again, there is risk of uterine membrane ruptures and core prolapse. Hyperextension of the fetal head, because once the fetal head is hyperextended, it means that bigger diameter. Bigger diameter, معناها we're going to end up with having entrapment of the aftercoming. Fetal anomalies, knuckle arm, يعني العمليات تكون behind the fetal head, يعني just like compound presentation. If you have pre-labor or premature rupture of membrane, or non-progressive labor, طبعا pre-labor rupture of membrane, amniotic fluid is going to be reduced, making vaginal breech delivery difficult. Again, the most important thing, you should have somebody who is skillful in conducting vaginal breech delivery, and that skillful person should be backed up with an operating room. Yani, that should happen normally. If a labor room is not backed up by an operating room, that labor room is not supposed to be functioning. Okay. Most favorable diameter for breech is the same for cephalic. Allow usually fully flexed fetal head. That's why extended fetal head is not is a contraindication for vaginal breech delivery, because it brings up bigger diameters. طيب لو جينا لقينا research what they're talking about. Next slide, please, Muaz. Usually they're talking, there is a term breech trials اللي هو دي اتعملت في 2000s. Okay, اللي هو short term outcomes اللي هو usually they found that immediate outcome there is increased perinatal and neonatal morbidity and mortality في الvaginal breech compared to cesarean section. لكن after 2 years اللي هو of 80% من الناس اللي هم الناس بدت فيهم الترايل حقتهم لقوا there is no difference between planned cesarean section and vaginal breech delivery. فعشان كده vaginal breech delivery still is a good and a safe option, even because when people start doing elective cesarean section for breech, because they were talking about perinatal morbidity and mortality. طيب, again, there is another study. It's an observational. It takes like 8,105 pregnant women with breech term singleton fetuses in different countries, French, Belgium, okay, maternity unit. And usually the cesarean delivery was planned in like 68%, and vaginal delivery was planned in 31%. Okay, and usually the neonatal outcome is similar in both groups. Yani, there are 2 studies talking about neonatal outcome is similar. That's why there is no advantage of giving elective cesarean section over breech presentation. Again, the RCOG and American College of Obstetricians and Gynecologists, again, they came with the same outcome. And usually planned vaginal delivery is reasonable in selected women with singleton breech fetus. Okay, type. Next slide. Vaginal breech delivery skills. Type. The also course continue to teach you vaginal breech delivery. Yani, it's part of the skill that people are trained when they come to the also course. Because usually vaginal breech delivery could be unanticipated and still do occur. يعني ممكن تجي واحدة with fully dilated and she's a breech. Then you are facing that. Okay, يعني ما حدا يقدر تقول إنه والله اليونت حقتنا أي breech for cesarean section. Just fully dilated and breech is coming out. Then you have to know how to conduct vaginal breech delivery. Again, a woman may decline. They can't refuse cesarean section and she wants just vaginal breech delivery. Okay, then you have to comply with her wishes. Okay. الحاجة المهمة شديد, when we conduct cesarean section for a breech, still actually we are doing breech extraction. Then we are going to deliver the limbs, we deliver the shoulders, and we deliver the aftercoming head. That's why it's a good opportunity that we train ourselves in how to deliver a breech. All you need is just you don't need to panic. بالراحة زي ما نحن بنطلعه في cesarean section. It's the same way of delivering the breech vagina. Okay, just during cesarean section you have the luxury of you can extend your incision. Type how you deliver, next slide, how you deliver a vaginal breech. Okay, vaginal breech but careful pneumonic زي ال ABC في instrumental delivery زي ال helper في shoulder dystocia. اللي هو C stand for check dilatation, presentation and the umbilical cord. يعني ما يكون make sure that there is no umbilical cord prolapse. Okay, لأنه cord prolapse is one of the common complications associated with breech presentation. Again, you have to wait for delivery لحد ما يصل level of the umbilicus. يعني allow the limbs to come out spontaneously till you reach the umbilicus. Okay. طيب. R stands for rotating the arms. اللي هو usually هنا we talk about delivering the shoulders لما تظهر ال inferior border of the scapula, then you can rotate to bring one shoulder anterior, you deliver the anterior shoulder, then you bring the posterior shoulder anterior, you deliver, then you end up with delivering after coming head. After coming head, usually it's advisable to use Mauricio Smelevit maneuver, اللي هو jaw flexion, shoulder traction maneuver. اللي هو في Mauricio Smelevit, what we need is we put the baby on our dominant hand. Okay, we flex the fetal head by putting two fingers on the maxillary bones. Okay, and then we keep the sacrum anterior most of the time. Then we lift the baby on the mother. Type. اللي هو check complete dilatation, avoid risk of head entrapment of the aftercoming head by the cervix. اللي هو always دي واحدة من complications الناس they don't like to happen because the breech is so smaller than the fetal head. Sometimes the breech could slip before the cervix is being fully dilated. You end up with the cervix entrapping the fetal head around the neck وتلقى الcervix يتفاجأ بأنه cervix not fully dilated. Okay, that's why we have to usually not to start pulling the fetal head to allow the fetal body to distend or to descend slowly to dilate the cervix. Check the presenting part, check umbilical cord prolapse, because these are the most important things when we are conducting vaginal breech delivery. Questions? في سؤال؟ Any question؟ يا جماعة سامعني؟ معاذ الناس دي ناموا ولا شنو؟
الو سامعينك ايوه
كويس. طيب فاهمين في سؤال؟
يس بوس
Yes.
كلير.
في سؤال ايوه.
طيب. تمام السؤال.
How I'll differentiate during labor, say the patient coming fully dilated and you say and this is breech is coming. If I have time to prepare for cesarean section, how I will differentiate clinically if this or how I to diagnose if this complete breech or frank. Putting it is clear يعني واضح لكن كيف أفرق إذا كان complete أو frank.
When you just do vaginal examination, a complete breech, you feel the feet just above the level of the buttocks. Okay, when you insert your hands or fingers inside, you can't feel the fetal limbs. Okay, just يعني ما حتكون بعيدة شديد من level of the buttocks. والفوتلينج بس لو واحدة من الليمس نزلت below the buttocks, you are dealing with footling breech. يعني ما شرط إلا تكون extended. Okay. You can know it. The second thing, if you do an ultrasound, you can see that the feet are near the shoulders of the fetal head. Okay, then you know that's a frank breech. Okay, في سؤال تاني؟
Can you please repeat the third and fourth step? Or هيتقالوا هسه قدام تاني؟
اللي هو شنو؟ حق السؤال حق الدكتورة ولا الكلام اللي كنت بقول؟
في careful نفسها في الستبس بتاعت careful.
طيب جدا. أول حاجة معاذ ممكن ترجع السلايد اللي قبلها. طيب اول حاجه في تشيك فور سيرفايكال دايليتيشن. يعني نحن قلنا the main complication اللي ممكن تحصل في البريتش انه البوتوكس could slip before the cervix being fully dilated. فعشان كده نحن نخلي البيبي to descend slowly together. Make sure that you are not going to end up with having the cervix entrapping the aftercoming head. والحاجة الثانية we check is a footling breech ولا frank. قلنا ممكن نعملها بالphysical examination. We can't do it using an ultrasound. والحاجة الثانية check for the umbilicus because umbilical cord prolapse is one of the common complications associated with breech presentation. Okay. Then next اللي هو في careful A await for delivery of the umbilicus يعني of the fetal umbilicus. يعني شنو؟ allow the fetal body to descend لحد ما يصل level of the umbilicus. يعني don't touch anything. All you need to do is just keep the back anterior. Okay. وليه الباك anterior؟ لأنه الباك لو بقى posterior you end up just like having an occipital posterior. Hollow of the sacrum, extension of the fetal head, entrapment of the aftercoming. That's why we have to keep the back anterior. Okay. طيب لما تحصل لنا نصل inferior border of the scapula هنا you can rotate to do a love that maneuver اللي هو to bring one shoulder anterior, deliver the anterior shoulder, then rotate to bring the posterior shoulder anterior and deliver. بعدين يفتح لنا شنو aftercoming. Aftercoming head Mauritius Malevich maneuver اللي هو jaw flexion shoulder traction. ده الاسم الثاني ليها. jaw flexion you put your fingers on the maxillary bones. زمان كان في ناس بيدخلوا اصبعهم جوا الهيد جوا الماوس of the baby to pull him out. دي مرات تعمل fracture of the mandible or dislocation. That's why you're not supposed to insert your finger inside the mouth. Okay, on the maxillary bones and flex the fetal head. قلنا flexion عشان يجينا smallest diameter. And always keep the back anterior. Okay. بعد ذاك لما الشولدرز الهيد start coming out you lift the baby, put him on the mother abdomen. Clear?
Yes, clear.
طيب. That's why check for cervical dilatation. Make sure that presentation is you don't have a cord prolapse and you don't have footling breech. Okay, next slide. طيب. When we come to vaginal breech delivery, when always any emergency ask for help. يعني ما شطارة إنك you are very skillful and I can do it alone. You need a lot of people to be behind. The second thing you need a neonatologist لأنه بعد الدليفري الناس expecting لو مذكرين كل الاستاديز اللي اتذكرت قبل شوية إنه usually people talking about immediate prenatal morbidity and mortality. That's why the neonatologist or pediatrician should be attending the delivery. يعني مش بعد ما نطلع البيبي أمشي نادي somebody else. Okay, he should be there. Okay, that's part of the ask for help. The second thing, you need somebody who's more expert than you should be there. Even if you are the most expert, you need some people to help you. Hand gently support the emerging breech. Always breech, don't touch, keep hands away. Like, the only thing is when the back starts rotating laterally or to the posterior, you have to keep the back anterior. And this is the only thing that you can do. Okay, when he reaches the umbilicus, اللي هو بيتكلم عن maintaining the sacrum anterior اللي هو back anterior. طيب you don't need to pull the baby. يعني مرات في ناس بيحسوا إنه والله it's coming slowly يمسكوه يجروه خلاص بحرق الروح كده. No, that's not good. لأنه pulling him you're going to cause extension of the fetal head. معناها you end up with entrapment. لأنه قلنا extension you end up having greater diameter of the presenting part. الحاجة الثانية you end up with having a knuckle arm. اللي هو اليد ذاتها يحصل لها extension تكون behind the fetal head. Okay? That's why you don't need to follow the temptation to start pulling the baby out. اللي هو breech extraction. Clear? واضح؟
Clear.
طيب. This is a love maneuver اللي هو for R rotating of the arm اللي هو usually لما نصل البلفيس usually when you need to hold the baby زي ما ظاهر في الصورة you put your hands on the pelvis not on the abdomen يعني ما بنمسك البيبي من ال soft abdomen you put your hand on the iliac crest and posteriorly on the sacrum okay you hold him by the bones not by the soft tissue لأنه ممكن يحصل injury للinternal organs liver ولا الspleen ولا كده. Okay, what you need is hand on bone not on the abdomen. Maintain the sacrum anterior الكلام ده قلناه, and then you rotate to bring one shoulder anterior, you deliver it, then you rotate to bring the posterior shoulder anterior and you deliver the anterior shoulder. Okay, rotate for delivery of the anterior arm in a hands are placed on the infant hips and pelvis, not on the soft abdomen. Okay, type. Enter. Next slide, Danny, next. Yes, yes. اللي هو enter this performing Mauritius Melevite maneuver اللي هو jaw flexion shoulder traction. يعني نحط البيبي on our dominant hand. Most of the time it's the right hand. A right hand دي الindex والmiddle finger on the maxillary bones. Will weight of the baby on my forearm. Okay, my left hand on the back of the baby اللي هو on the occiput to push the occiput and the shoulders اللي هو my thumb and a small finger on the shoulders to pull him out. You need an assistant to perform suprapubic pressure to help you in delivering the aftercoming head. Okay, clear this step?
Clear.
Yes.
Five. That's where next, yes, that's where you put your fingers on the maxillary bones. And maxilla usually is in strong bones and unlikely to be traumatized. Don't insert your finger inside the mouth and don't go high up to insert them inside the eyes of the neonate. Okay, type. Next, usually sacrum should be kept anterior also most of the time because sacrum anterior mean that just like occipito anterior mean that smallest presenting diameter, and usually the fetal head could be delivered easily. Type. Lift the baby to the mother. Anticipate increased likelihood of needing resuscitation. Next slide. That's why the baby once out, he need to be handled by pediatrician for assessment. But if the infant is vigorous, yani crying immediately, he's everything, all you need is dry and wrap and put him on the mother's skin, okay? And allow delayed clamping of the cord. Yani usually early clamping of the cord kind of a classical teaching, usually it ends up is having neonatal anemia. That's why wait for the cord to stop pulsation or wait for 1 to 2 minutes, allow the blood on the placenta to drain on the neonates, and then put your 2 clamps and cut the umbilical cord. Okay, next. Complication that could happen for breech delivery is knuckle arm. اللي هو the hand should be over the fetal head on the back, or entrapment. قلنا الانترابمنت بتحصل من ال body of the breech slip before the cervix being completely dilated. Okay, and umbilical cord prolapse and is a common complication of breech presentation. Knuckle arm. Okay, one or both arms strap around the back of the neck. Okay, طبعا دي بتخلي presenting diameter bigger and it prevent spontaneous delivery. It's prevent by allowing spontaneous delivery to umbilicus. يعني شنو how can we prevent knuckle arm؟ نخلي البيبي to come out slowly لحد ما يصل level of the umbilicus without doing anything. The only thing we do is just keep the back anterior only. And if you start pulling him out, you're going to end up with knuckle arm. Okay, lobsit rotation اللي هو أو lobsit maneuver usually attempted in the direction that anterior arm is pointing. يعني احنا we rotate the baby في الاتجاه the anterior arm is pointing to bring the posterior arm or posterior shoulder under the pubic symphysis to avoid excess force to the cervical spine and trauma. يعني لما تحصل لنا knuckle arm بنمسكه زي المسكه بتاعت اللبزة maneuver usually on the pelvic bones and you rotate on the direction the anterior arm is pointing. Okay, and try to sweep down by flexing the elbow. اللي هو دي الصورة هنا. Next, yes. هنا where the anterior arm اللي هو دي الموجودة on the left side of the screen. Okay, we rotate him towards that direction, and usually what happens, الانterior arm دي بتبقى posterior, وبعدين احنا we deliver the other arm, then we deliver the left arm out. Okay, clear؟ يعني في نفس الاتجاه بتاع الارم اللي بتقابلها دي we rotate him towards that direction. Okay، اللي هو في الصورة دي واضح. طيب then you see once the arm comes out, أيوة الصورة اللي بعدها we can deliver the arm outside. Okay, we hold the arm and get it out. طيب management of head entrapment. قلنا مرات when the cervix not being fully dilated and the body comes out, the head can be entrapped by the cervix, not fully dilated cervix. اللي هو how we manage them, medical management. ممكن ندي nitroglycerin اللي هو we know that's a relaxant. Okay, relaxation of the cervix اللي هو ممكن نعمل surgical management. Incision of the cervix. Usually الناس they incise at 12 o'clock and 10 o'clock. بيسموها Dearson incision. Okay. مرات ممكن entrapment inside the pelvis and below the cervix اللي هو at lower level. At that case we can do instrumental delivery. The forceps that we can use for delivering after coming head يسموه Piper forceps. Okay. Abdominal and vaginal maneuver to increase flexion of the fetal head مرات can be used اللي هو ممكن fundal أو suprapubic pressure on the fetal head. ومرات we can do symphysiotomy اللي هو separating the symphysis pubis, لكن طبعا still there is a risk of injuring to the urinary bladder or the urethral injury لأنه الurethra is just directly below the symphysis pubis. ومرات ممكن يحصل لهم they could have difficulty in walking after doing symphysiotomy. That's how the Dearson incision is being done. We just bring two ovum forceps and you cut between them عشان بعدين نجي نخيط الحتة. And usually, as I mentioned, you do it at 10 o'clock and usually what you find pathological retraction ring. يعني there is a big demarcation between upper uterine segment and lower uterine segment. اللي هو اللي بيحصل شنو انه الupper segment it contract كل المسل تبقى very thick والlower segment تبقى very thin. A demarcation between upper uterine segment and lower uterine segment could be visible even above the woman's skin. يعني قبل ما نحن نفتح اليوترس ولا اي حاجه you can't see that there is a big retraction ring that's clear. Okay. طيب next, if we come to face presentation, this is a very rare presentation but you can encounter it. في الفيس presentation عندنا حاجتين, mento anterior and mento posterior. And usually on a face presentation we are talking about hyper extension of the fetal head. Okay. طيب, and usually the mechanism of delivery of the face is by flexion. Okay. لو ملاحظين هنا في الصورة a symphysis pubis is very small but the sacrum is a big one. Okay, that's why mento posterior the chin can slip below the symphysis pubis and come out, and the head is going to be delivered by flexion. يعني لو ملاحظين أول صورة هنا the fetal head is hyper extended. When the fetal head comes out it's flexed. Okay, that's why mento anterior can be delivered, and even you can use instrumental delivery and can use forceps. Actually you cannot use vacuum for face presentation. Okay, let's see mento posterior. Next slide please. Mento posterior actually it's very difficult because flexion cannot happen because you have a very long sacrum. Okay, it cannot allow flexion of the fetal head, and the fetal head cannot slip below. That's why usually if you have mento posterior, either it could rotate to mento anterior to be delivered or cesarean section. Okay, that's why mento posterior C-section, mento anterior can be delivered vaginally. Clear?
Yes.
Type. Thank you. Type. Compound presentation when we have arm, okay, or forearm coming beside the fetal head. Okay. The last thing we talk about umbilical cord prolapse, and usually the commonest risk factor for umbilical prolapse is, or cord prolapse is, malpresentation. We talk about footling is the commonest. Footling is the risk of cord prolapse come to up to 20%. Okay, and 15 to 18%. That's why footling usually people don't allow vaginal bridge delivery, because this is very high risk for cord prolapse. Okay. Prematurity is a risk factor, polyhydramnios, high presenting part. Okay. But it could be iatrogenic when we do ARM before the fetal head is well engaged. We end up having cord prolapse. Okay. Prolapse of the umbilical cord in a footling bridge is the commonest. Sometimes you can't find the cord inside the vagina, and usually talk about prolapse when the membrane ruptures. If the membrane are intact, we talk about cord presentation. When the cords come outside the vagina or inside the vagina, it still is a cord prolapse. And if the cord comes out after the membrane rupture, that's a cord prolapse. Membrane intact, we talk about cord presentation. Type. Once cord prolapse happen, that's an obstetric emergency. Call for help. Make sure that the baby, next slide, please. Make sure that the baby is alive. And usually palpating the cord is not advisable because it can cause a spasm of the blood vessels. Okay, then usually an ultrasound to look at the fetal heart to see if the baby is alive. Okay, but don't touch the cord because of feeling that the baby is alive or not. What you can do is replace the cord inside the vagina, but not behind the presenting part. يعني رجعه inside the vagina and keep it inside. الحاجة الثانية المهمة, we need to make sure that the presenting part is not pressing on the cord. اللي هو hold the presenting part of the cord. دي بتتعمل شنو؟ Either put a Foley catheter and infuse the bladder with 500 ml of normal saline. The distended bladder will keep the presenting part away from the cord. Okay. أو disengagement of the presenting part, ولا putها on knee chest position ولا trindle in bed position عشان نقلل الإفكت. طبعا أكيد لو هي بتاخد في oxytocin, you have to stop oxytocin to stop uterine contraction. Again, if the contraction are strong, sometimes you can use tocolytic drugs, okay, to stop contraction and stop, because if the cord is being pressed by the presenting part, you're going to end up with having fetal hypoxia and fetal death. And then if the cervix is being fully dilated, طبعا instrumental delivery is a good alternative. Otherwise, if the cervix is not fully dilated, you have to go for an operating room to save the life of the baby. Questions? في سؤال؟ طيب, how we prevent cord prolapse? Identify who's at risk. Malpresentation, high presenting part, okay? And again, telling the woman that if she had rupture of membranes at home, that she should be anticipating that she might be having a cord prolapse. Okay, when the fetal head, you are not supposed to do ARM when the station is very high. Okay, rupturing the membranes when the fetal head is not engaged is a risk factor for cord prolapse. Okay, and if you need to do it, then it should be under double setup. What do you mean by double setup? Doing ARM inside the theater. Cord prolapse, you go for cesarean section immediately. And the woman is scrubbed and everything is ready for operation. Next slide, please. Okay. Right. Multiple gestation. This is our last talk. I'm sorry. I know I took a long time. Okay. Usually around 4% of ultrasound US birth, sorry, is usually why people worried about multiple pregnancy, because there is an increased risk of perinatal mortality up to 5 times. Maternal complications associated with multiple pregnancy include hypertension, gestational diabetes, anemia, hyperemesis gravidarum, placenta previa, pulmonary hypertension, operative delivery. Okay, a lot of complications associated with multiple pregnancy. Dizygotic twins, يعني non-identical, one male or female or different colors, just like brother and sisters اللي هو coming from two different ovum is 2/3. 1/3 is monozygotic coming اللي هو identical twins. Next slide, please. طيب how you diagnose multiple pregnancy? Usually early scan is the best thing. طبعا history, induction of ovulation is associated with an increased risk of dizygotic twins. Having family history of multiple pregnancy, usually West African people have highest risk of having dizygotic twins, hyperemesis gravidarum. Having uterine size more than dates, multiple pregnancy comes in the differential diagnosis, early onset preeclampsia, high level of alpha fetoproteins, okay, auscultation more than one fetal heartbeat, having polyhydramnios. All these make you think that about the possibility of having multiple pregnancy. Associated neonatal complications of multiple pregnancy include preterm delivery, طبعا overdistension of the uterus, having discordant growth of twins, especially if you're having twin transfusion, congenital anomalies because you have twins, then most likely it could be double, intrauterine fetal demise, having vanished one twins, or is a risk factor. ما عايز أعرف قاعد شغلني سريع. كويس. Presentation of twins, both being cephalic is 40%, or one cephalic. The second non-cephalic is another 40%. And having cephalic presentation is up to 80%, and non-cephalic first twins is around 20%. Next type, recommended mode of delivery of twins. Twin A اللي هو أكتر واحد, the lowest twin. If non-cephalic, cesarean section is advisable. If both cephalic, vaginal delivery. If twin A is cephalic, twin B is non-cephalic, it's controversy, but I say vaginal delivery still has a place in this place. Okay. Is it safer to do cesarean delivery for all twins? Usually, the primary outcome in mortality or serious morbidity is the same cesarean versus vaginal delivery. And for twins, if I talk about morbidity or mortality, it's almost the same whether they deliver vaginally or they deliver by cesarean section. اللي هو 60% of planned vaginal group deliver twin A vaginally. يعني 60% الناس اللي هم بيحطوهم for vaginal breech delivery they deliver first twin normally, and only 4% cesarean rate for twin B. فمرات لما يحصل delay ولا mismanagement الثاني يجي يحصل cord prolapse ولا يحصل entrapment of the second twin ولا يحصل abruptio, then we end up with doing cesarean section for a second twin اللي هو 4%. طيب اللي هو the American College of Obstetrician, and usually they are recommending for twins, usually prenatal outcome for twin gestation in which the first twin is in cephalic presentation are not improved by cesarean section. يعني من الأول يكون cephalic, doing cesarean section will not improve the outcome. Okay, if it's better first cephalic, cesarean section is advisable. Women with either cephalic presentation twins or cephalic non-cephalic twins should be counseled about vaginal delivery. اللي هو ده الكلام اللي قبل شويه نحن هنتكلم عنه second non-cephalic controversy. Actually, cephalic first twins you have to talk about vaginal breech delivery. Okay. طيب delivering twin B when non-cephalic, twin B could be transverse, could be footling, and usually in that case having twins, the second twin coming after delivering the first being transverse or having footling, you can't do internal version. اللي هو يعني شنو internal version؟ سامعني يا جماعة؟
Yes.
اوكي تمام. internal version مين ندخل يدنا جوا نمسك الفيتس نجيبه بريتش. That's what I mean by internal podalic version. لأنه the presenting part could be high, you cannot use an instrument to deliver to. That's why it's called breech extraction. breech extraction mean what زي ما نحن بنعمل في السيزيريان section. نطلع الليمز اللي هو الفيتس، نطلع الشولدرز، نطلع الافتر كامينج هنا. اللي هو دي the only place that you can do internal podalic version and breech extraction for the second twin. لأنه هنا already first twin is being delivered, the cervix is being fully dilated. Okay, there is no evidence of cephalopebic disproportion. Okay. طبعا still for twin B being non-cephalic, if not an urgent, ما في cord prolapse, you can do external cephalic version. Okay. And breech delivery is a reasonable choice when external cephalic version is unsuccessful or not attempted. يعني for the second twin هو جاي breech, okay, then you can allow to go for vaginal breech delivery. Okay, مرات ممكن يكون immediately after delivering the first twin in the good strong contraction and the breech come distending the vulva, then you allow vaginal breech delivery. يعني ما حتقول لا إلا ألف وأرجعه كفلي. Okay, and again the most important thing to conduct vaginal breech delivery, you have to be trained in conducting vaginal breech delivery. Okay, طيب, in summary, there are many malpresentations, and usually they could be diagnosed by examination, they could be diagnosed by ultrasound. Okay, and usually you have to make sure if you have a malpresentation, try to find a cause. There is an association: prematurity, increased liquor, reduced liquor. Try to find what's the cause. Okay, and again, malpresentation associated with complications. We have to be aware about these complications, and we have to make sure that to reduce the risk of these complications. Vaginal breech delivery is considered, vaginal delivery may be considered for occipito-posterior, for breech, and even for men to anterior face presentation and compound presentation. يعني ديل كلهم ممكن نستعمل فيهم. Still is an option. يعني ما حنقول إنه occipito-posterior always for cesarean section ولا breech always cesarean section ولا all face for cesarean section. Still there is a place for vaginal breech delivery. أنا myself personally اتكلم في الوضع بتاع السودان هنا ده, we have to consider vaginal delivery first. Okay, يعني واحدة ممكن تجي تعمل لها cesarean section for one reason, بس because the baby is coming breech, next time تكون في very rural area that they don't have a hospital, they don't have an access for cesarean section, she ended up having rupturing of her uterus. تمام. Vaginal delivery is usually recommended for twins when twin A is cephalic. Okay, يعني once twin A is cephalic, vaginal delivery is a reasonable option. Okay, any question?
I have a question.
Yes, welcome.
هل في فرق في الجايدلاينز للتوينز دي سواء كانوا مونوكورونيك أو دايكورونيك especially regarding a second non-cephalic twin؟ إذا كان مونوكورونيك هل external cephalic version is يعني possible؟
Well, one thing you give them the chance of vaginal breech delivery. Already the first twin is being delivered. Then there is no reason why the second twin cannot be delivered. Okay, even can be delivered by external cephalic version. نحن دائما بنتكلم إنه vaginal delivery is safer. بعد ذاك أصلا حصل complication for the second for twins itself. يعني usually المونوكوريونيك الناس بيتكلموا خايفين من twin transfusion. ما حصلت أي حاجة و they are going normally. There is no reason why you should treat them differently. Okay, you have to treat them the same way. This cephalic or non-cephalic. That's what you should be doing. And that's a reasonable thing. Okay. أي سؤال تاني؟
تفضل يا شاهد. شاهد عندك سؤال، تفضلي.
السلام عليكم.
سلام، مرحبا بك.
بس المراجعة اللي بتلاقيه كل الحاجات بنتكلم عن البريتش. أنا بس يعني ليش الترانسفيرس تايب بيقول لي مع انه البريتش في لحظه ما الحاجه دي يعني ما فيها كلام ترانسفيرس فور سيريان سيكشن لو جات الليبر ما مشكله، لكن لو كانت ترانسفيرس وهي لسه مثلا 37 ويكس
والبيشن العكس ترانسفيرس لاي دي هي قطعت لك نص المشوار واصله. طيب اوكي كونتينيو.
ايوه
يس مش سؤالك انه ترانسفيرس لاي in labor ما خلاص she's contracting. There is no mechanism to conduct vaginal delivery for a transverse line. That's why cesarean section. لكن هي ما عندها contraction. يعني مثلا جاتك في العياده المحوله عيانه لقيتها ترانسفيرس لاين. على العكس الاكسترنال كيفاليك فيرجن في الترانسفيرس لاين اسهل من الاكسترنال كيفاليك فيرجن في البريتش، لانه في البريتش انت دايره تلفيه كله لحد ما تقاس لو مذكرين لا من قبل شويه تكلمنا عن الاكسترنال. هو مشى معك نص المشوار. تمام؟
ما انا معاك، لكن مثلا كايفيدنس يعني بتكلم عن الاكسترنال كيفاليك فيرجن فور بريتش برزنتيشن.
يس.
الترانسفير سلايد هاي ما لاقاني في اي حته، والبيشن يعني كانديديت فور فاجينا ديليفري نو كونتر انديكيشن فور سي اس شي كان جو فور اكسترنال كيفاليك فيرجن. يعني ما في حاجه ذكرت كده بالنيم، مع انه يعني لوجيكالي اسهل لي الترانسفيرس من البريتش لانه اوريدي تحت نص.
يلا اوريك ليه. لانه هم عاده الايفيدنس اللي انت
فلكن ما في حاجه
كده فاهمك. الحاجه اللي انت بتتكلمي عنها هم بيتكلموا عن الترانسفيرس لاين ان ليبر. فهمتي؟ once a woman is being labored she is having a transverse line, then usually it's very difficult to go for. خاصة هم لما نتكلم عن transverse line even some might be talking about extreme. مثلا transverse line with hand prolapse خلاص that's even if the baby is dead sometimes the only option you have is doing cesarean delivery. لكن إذا كان transverse line جات واحدة في المعدة المحولة ما عندها أي مشكلة ماشية بالكورينا وممبرين intact ما عندها أي حاجة. I guess it's unfair not to attempt external cephalic version. Okay.
Okay, شكرا.
عفوا. Any question?
السلام عليكم دكتور أمير.
سلام حبيبي.
الحمد لله على السلامة والإسلام. معلش بس سؤال عن delay cord clamping. ممكن instead of it إنه نعمل cord milking؟
نعم.
delay cord clamping. delay cord clamping.
أيوة.
active management of secondary stage of labor. ممكن بدل نعمل cord milking؟
هي طبعا الفكرة كلها إنه الناس they need some of the blood that's in the placenta to drain on the baby. Okay. فالناس بيتكلموا إنه just allow it to drain يعني wait for 1 to 2 minutes to allow the blood in the umbilical cord to drain for the baby. وعادة الناس في cesarean section what people do is just they milk the umbilical cord. فايس an option يعني. Okay. لو مذكر زمان التيتشنج بتاع الاكتيف مانجمنت اوف ذا third stage of labor بيتكلموا عن giving oxytocin drug, early cutting and clamping of the cord and control cord traction. مذكر الكلام ده؟ سامعني؟ الو؟
ايوه سامعك.
كويس؟ كان زمان دي the classical teaching. Oxytocin drug, early cutting and clamping of the cord and control cord traction. النتيجة إنه طلعت إنه كمية من الناس بيحصل لهم neonatal anemia. عشان كده ال early cutting and clamping of the cord بقى the classical teaching now is delayed clamping of the cord. Okay, for milking of the cord it could be a reasonable option. I don't see why not, because we do it during cesarean delivery. Okay, any question? Yes.
شادي انت فتحت المايك وليك سؤال ولا بس؟ شادي تفضل.
صوت ما واضح؟
كده واضح.
السلام عليكم دكتور أمير.
سامعك.
ألو.
أيوة مرحبا بك.
I want to ask if any primary gravida with a breech presentation for C-section.
لا الكلام ده قبل كنا بنتكلم عنه. البرايمري جرافيدا من الناس الممكن external cephalic version could be difficult. Okay, لكن any woman who come with breech presentation when she reach term you have to offer her external cephalic version. لو مذكرة قلنا wait if the breech presentation wait you do nothing till she reach term. Once she reach term then you have to either offer her external cephalic version. Even if you don't know how to perform external cephalic version, refer her to somebody who is expert in doing external cephalic version. بعدين السكسس rate حقته is operator dependent. تمام؟ Then if you didn't offer الناس they don't prefer trial of vaginal breech delivery for primary gravida لأنه her pelvis is not tested. لكن لو عملت estimation of the fetal weight and bigger average fetal weight and she's an average human build, still there is no contraindication that she can't deliver vaginally. And that's usually fear of litigation, fear of bad outcome. That's why usually primary gravity with breech cesarean section. عرفتي؟ لكن is not the only way. فعشان كده مرات كثير الحل شنو؟ انه you counsel the woman herself. تيجي توريها والله في external cephalic version، في vaginal breech delivery، في elective cesarean section. اي واحده من ديل you have to talk about advantage and disadvantage. It's just like a menu. بعد ذاك whatever she decide and accept that should be the management plan اللي هو agreed، عشان بعدين ما تقول له والله ما كلمونا، ما قالوا لي انه ممكن يحصل كده. عرفتي؟ كلير؟
يا شباب في لينك موجود في سيرفي لازم نملاه قبل ما نخلص المحاضرة. بسيطة، سيرته بسيطة ومهمة، ده بيعتبر لنا اتندنس يعني. فنخش على الرابط الموجود على الشات ده ونملى السيرفي.
أي سؤال؟
سامعيني يا شباب؟ في رابط على الشات سيرفي لازم نملاه. اوكي.
الو.
ايوه سامعيني؟
ايوه مرحبا.
ايوه دكتور، شكرا على المحاضره. بسأل how many time أو how many trials I should try أو I should attempt for external cephalic version. زي إنه أنا جربتها مرة ورجع ثاني للبريتش، كم مرة بقدر أحاول؟
هي طبعا normally we do it at term عشان ما يرجع مرة بريتش. زمان
أيوة بعد الترم يعني.
At term usually is not supposed to come back to breach. لكن أنا بصراحة I don't know about how many times you should try. لكن always when you do it at term is not supposed to go back to breach. يعني a chance of after external cephalic version اللي هو يبقى successful إنه تاني يرجع breach is not that big. أنا بصراحة ما مذكر الفيجر لكن is not big. لكن still there is no number of times. Okay. If you let me know.
Okay. Thank you.
إن شاء الله. Okay.
في سؤال يا شباب؟ تفضلوا. دكتور أمير معاكم.
بس عندي كومنت يا دكتور أمير، ما سؤال هو.
مرحبا بك.
الاكسترنال كيفاليك فيرشن مفترض يكون في وضع زي السودان في الثيرد وورلد عموما، هو حاجه تدرس وتطبق ايضا يعني. زمان اساتذتنا كانوا بيعملوه وكانوا ويل تريند يعني. الله يرحمه دكتور عبد الرحمن عبد الحفيظ والناس دي تدربنا عليهم يعني، ويعني تلمذنا على يدهم. nowadays even most of the obstetrician they don't know how to do it. ونحن الناس اللي اعتبرنا نفسنا جونيور obstetrician او جونيور ريجسترالز وكده برضه يعني we are not seeing it nowadays. فكل البوستات بيسكشنوا على طول برايمري جرافيدا بريتش يلا سيزيريان سكشن، حتى they are not showing us how to do يعني بنلقاه في كورسات زي كده. دي حاجه. الحاجه الثانيه في الاوضاع الحاليه في السودان، لو انا عايز اعمل اكسترنال كيفاليك فيرشن لازم المستشفى تكون فيها سي تي جي، الترا ساوند جنبي، سياتر جنبي، والحاجات دي بصراحه دلوقتي هي ما موجوده. يعني اقدر اقول انه non applicable الاكسترنال كيفاليك فيرشن رغم من سهولته ورغم من انه هو جايد لاين should be applied يعني، لكن في صعوبه تكنيكال يعني ولوجستيه، حاجات لوجستيه يعني. فنتمنى انه الوضع يتحسن.
هي طبعا
يعني
you are right. You are right. لكن هي طبعا التراساوند nowadays اكثر المستشفيات في اي حته بتلقى فيها التراساوند ماشين موجوده. كويس. حتى ما شرط انه لازم يكون في سي تي جي. مرات بالبينارد زمان لما انت كنت تتكلمي عن الناس كانوا بيعملوا اكسترنال كيفاليك فيرشن they don't do a CTG لكن they just listen to the fetal heart sound. لكن الفكره برضه في حاجه you have to put on mind. مرات الناس they're not accepting a bad outcome يعني الليتيجيشن وكده. فusually people sometimes they don't want to go. مرات السيزيريان section is a good escape for the doctor himself rather than for the patient. كويس. اما talk about private practice مرات في financial benefit of doing a cesarean section. خلاص primary gravida breach cesarean section. فهي still انا I guess the only idea ما في حاجه من غير ما في risk. Everything has its risk and advantage. So what you need is telling the patient والله frankly يعني in a neutral way. الاكسترنال كيفاليك بين دي الريسك ودي الكومبليكيشن. لو انت عارف مرات الريسك والكومبليكيشن ممكن rupture uterus, abruptio placentae, fetal death, it could all happen. تمام. a cesarean section is safer لكن next time placenta previa, placenta accreta مرات نحن اكثر الحاجات for the time being خلاص نخلص من المره دي، بعد ذاك المره الجايه يحلها ربنا. مرات الناس بتكون شغاله لكن still why not get the final decision rest on the woman herself. Tell her about advantage and disadvantage of each one of them. Vaginal breech delivery, external cephalic version, and cesarean section. أي واحدة advantage و disadvantage. بعد ده كده when she take a decision that's an informed consent, informed decision. يعني when she take that decision she know in what's the risk, why she took that decision. Then the decision rests on the woman herself, not on the doctor. Okay, any question?
Thank you very much دكتور أمير. شكرا جزيلا.
Okay, welcome. العفو.
شكرا يا شباب لكم كلكم على حضوركم الدائم والفرصة التجربة الجميلة. حنشوف مع بعض التجربة دي كانت ماشية كيف، لكن بنشكركم كلكم على صبركم والظروف الصعبة والنت اللي بيقطع والكهرباء وكده. بنشكر كل الزملاء اللي ساهموا في كل المجهود ده، ابتداء من مجيد جبورة من ايرلندا ومن الباهي، كل الناس اللي بذلوا مجهود، دكتورة دوريا ريس، دكتور أمير، دكتورة هالة وأماني وبدر الدين من قطر، دكتورة ماندي، كل الناس بنشكرهم، وإن شاء الله تكون الفائدة كبيرة والناس تستفيد فائدة كويسة. بذكركم تاني ضروري نملأ السيرفي الموجود على الشات لما نطلع من الزوم.
يا دكتور معاذ بس معلش لو سمحت لي، اتصلت الدكتورة شاهد هسي وبتعتذر يعني انه امبارح هي على اساس انه يوم فل، فافتكرت انه المحاضرة بتاعت الليلة وحابة انها تدخل وتسلم على الناس، فنحن حنشوف زمن مناسب نخلي الناس تسلم عليها، وهي يعني جاهزة انها تقدم اي يعني تجاوب على اي سؤال، او الناس اذا طالبة حاجة معينة هي ممكن تقدمها لهم.
منى اسف بس عشان كده حاليا يا منى حبيبي نحن موجودين حاليا يا منى.
طيب ايوه يا معاذ.
خلينا نخش حاليا.
لحظه طيب، اديني دقيقتين اشوفها اذا هي هسه ممكن تدخل عليكم طوالي، وبنعتذر والله. طيب دقيقه.
يلا يا جماعه شكرا جزيلا. enjoy being with you. معاذ انا في سوبا وماشي على البيت. يلا شكرا جزيلا.
شكرا يا دكتور امير، كثر خيرك. شكرا لك.
العفو الله يبارك.
شكرا يا دكتور.
العفو الله يبارك.
شكرا.
طيب يا شباب، بكره طبعا موعدنا لازم نجي بدري عشان الهاندسون الستيشن، عشان نقدر ناخذ زمن كويس في الستيشن، ونبدا 8 شهر بنكون بدينا الستيشن. نحاول نجي قبل يعني على الاقل 8 الا ربع او 8 الا 10. لازم نكون موجودين في صوبة عشان نعرف الكلر بتاعنا شنو، التوزيع بتاعنا والتاج بتاعنا، عشان طوالي حنخش على الستيشن. فلا بد اذا 8 هنبدا لازم قبل 8 بربع ساعه نكون عرفنا التوزيع بتاعنا والستيشن بتاعتنا هنخش، لانه بكره الزمن ضيق. نحن ما قاعدين نتكلم كثير. القايد الكلر بتاعك يعني كل ستيشن ما في زول بيقول لك تعال امشي هنا ولا كده، بالعكس انت الكلر بتاعك بيكون يتحول، مكان الكلر بيتحول هنتحول معه. يعني لو واحد ريد بيشوف الريد ده ماشي من حته لحته بيمشي معاه لحد اخر اليوم، بيكون عملنا كفر لكل الستيشن اللي حنشتغله. فضروري نجي قبل الزمن، لو جينا مع الزمن حيكون مشكله وما حنقدر. بعدين الستيشن ما بتبدا عادي، يعني بنبدا مره واحده وحنفوت علينا جزء كبير، فنحاول نحرص نكون موجودين قبلها. بكره اخر بعد ننتهي الستيشن هنعمل برضه ميتنج صغير حنتكلم فيه عن الامتحان شكله حيكون كيف، وكل حاجه حنتكلم عن الامتحان باستفاضه كثيره وحنشرح كل حاجه، عشان كده الناس ما تقلق وما تشيل هم الامتحان حاليا. لو في اي سؤال انا معاكم، ولو اي زول خلص السيرفي وداير يطلع طبعا ممكن طوالي يطلع، لكن تذكروا انه بكره لازم نكون موجودين قبل 8 في صوبه. منى الباهي معانا صح؟ منى دكتوره شاهدة قريبه؟
ايوه دكتور معاذ، ايوه معاكم. دكتوره شاهدة 10 minutes وحتدخل معاكم، ما حتاخذ من وقتكم كثير. اذا في اي زول عنده سؤال او محتاج حاجه هي تقدمها او تشرحها يجهزها، بس مثابه هي تعمل بريبريشن شويه وتدخل.
تمام. شباب ملينا السيرفي صح؟ في زول ما فتح معاه السيرفي ولا حاجه يا شباب؟
السلام عليكم.
دكتورة اسماء اتفضلي.
ايوه سؤال خارج الاولسن.
مرحبا بك.
بنزل من الصب سبيشال المفتوحه في المجلس حاليا.
والله يا اسماء صعب اجاوب لك على ده، لكن ممكن اسالك نكون هناك حنكون جاوبناك، لانه ده ما يعني حنسالك.
خلاص ضروري عليك.
لانه كان بدا كلام عن
ان شاء
الجاين،
الله.
بدا كلام عن الانفيرتيليتي. ناس الجاين عملوا لهم، ناس فيصل الجلال عملوا لهم حاجه كده، لكن ما عارف بدوا ولا ما بدوا. وناس الانفيرتيليتي برضه كان عملوا.
سمعت انا بالانكولوجي.
الانكولوجي اي ناس فيصل الجلال.
ايوه انا سمعت بالانكولوجي.
ايوه بالضبط كده. ناس الانفيرتيليتي برضه كان عملوا حاجه جازوا المجلس بتاعهم دول الاثنين، لكن حنتاكد عنهم ثاني لما نحن نكون موجودين في شوبه بكره ان شاء الله.
يلا ربنا يسهل ان شاء الله. شكرا لك.
تقريبا الساعة 5 يا دكتور وسيم.